Cynnes I chi yma I neuadd reichel y Mangor ar ddiwrnod, ar ddiwrnod niwlog o Dachwedd, byddwn ni'n dweud. Croeso cynnes I bawb sydd yn ymuno ni ar-lein ar gyfer I cyfarfod bwrdd. Croeso cynnes I chi sydd yma hefyd yn y neuadd. Rydyn ni'n falch iawn bod pawb wedi ymuno â ni. Mae gen ni agenda eitha hir yn unol ar arfer a mae gen ni nifer o faterion pwysig i'w trafod. Byddwn ni yn hwylio peth sylw ar ddilyniant i'n cyfarfod bwrdd diwetha ynglŷn â'r gwaith o gwmpas adrannau brys a byddwn ni'n rhoi sylw wrth gwrs i'n perfformiad mewn meysydd eraill yn unol ar arfer. Dwi eisiau dweud hefyd, does na ddim ymarfer tân heddiw wedi cynllunio os oes na larm tân yna, dyn ni'n mynd allan I tu blaen yr ystafell drwy drws sydd wedi nodi fyna. Diolch I bawb sydd wedi helpu gyda'r dechnoleg heddiw ag mae'r ystafell, mae'n acwstig eitha da yn ystafell, ond gai annog bawb I godi lleisiau os gwelwch yn dda. Wrth y croesawu chi, dwi eisiau croesawu yn arbennig Paul Lambert I gyfarfod bwrdd cyntaf. Mae Paul wedi ymuno â ni fel cadeirydd ein pwyllgor archwilio a'r person sydd efo'r gorolwg o faterion ariannol. Croeso cynnes iawn ato ni, Paul, wedi bod yma am ryw fis neu rhywbeth felly, dwi'n meddwl. About a month you've been here, I think, already.
To this meeting room many times.
Yeah, yes, yeah. Yeah, you are still, are you still, I think, council member of the university and have served on the council and the audit committee for a very long period?
I've been on the university council for 9.5 years and I stood down from the university audit and risk committee last week.
Right.
And I chaired that the last 3 years.
And I think you've been in the board now, is it about a month?
Been a member of this board for, yes, just over a month.
Just over a month. Croeso cynnes o beth bynnag.
Yeah.
Sorry. Reit, ymlaen â ni i'r cyfarfod ar agenda. Yr eitem gyntaf felly, da ni wedi derbyn nifer o ymddiheuriadau ac yna yr eitem nesaf ydy datganiadau o fuddiant. Gai I ddechrau drwy darlinellu datganiad o fuddiant sydd eisoes wedi cofrestru sef mod I yn breswylydd ym Mhenygroes yn y Ffynonell Gwynedd ac mae Canolfan Lleu yn un o'r prosiectau sy'n cael ei enwi yn un o'r eitemau sy'n cael ei drafod heddiw. Unrhyw un arall sy'n eisiau datgan fuddiant? Dyfed Jones ysgol da.
Yn yr un modd, dwi'n meddwl mae canolfan iechyd Caergybi, dan sylw, a mae yna gydweithio efo'r cyngor sir a cynghorydd sir, wedyn jyst eisiau datgan hynny.
Diolch yn iawn. Unrhyw un arall eisiau datgan fuddiant ar unrhyw eitem sy'n cael ei drafod heddiw ysgol da. Unrhyw un? Na, felly ymlaen â ni at yr eitem nesaf. Eitem 1.3, cofnodion y cyfarfod blaenorol, cyfarfod a gynhaliwyd Medi 25. Eleni, pawb yn hapus I dderbyn y cofnodion yna. Mae cyfle I ni edrych ar faterion yn codi a'r camau gweithredu. Droi at pam falle am y camau gweithredu action log. Anything to note, please, Pam?
Diolch yn fawr, Cadeirydd. I think the action log is self-explanatory. There's one further note, just I've been alluded to by one of the independent members, was in relation to the discussion on priorities, so I'll make sure that features in an update because we don't lose that. So other than that, and then just really wanted to draw to the board's attention in relation to a follow-up question that was raised by Mr. Graves. Whilst we have been in correspondence and had some meetings with Mr. Graves, I'll just follow up outside the meeting just to conclude that that action has been completed. So I would propose, if that's okay, we will put that in the actions while I follow that. Apologies that having been concluded dros time. Executive colleagues will be able to answer any other further points. Diolch yn fawr.
Diolch yn iawn. Pam unrhyw gwestiwn gen rywun ar hynny? Na? Os nad oes, ydyn ni'n hapus i dderbyn felly y camau gweithredu eu bod nhw'n gywir. Ie, pawb yn hapus. Diolch yn iawn. Ymlaen at eitem 1.5, sef yr eitem rheolaidd. Da ni'n cael fel bod eitem profiad. Da ni'n ei alw a da ni bob amser yn awyddus i dderbyn mewnbwn gan staff a pleifion a'r galloedd i ni gael syniad o beth ydy profiadau pobl naill ai'n gweithio yn y bwrdd iechyd neu profiadau pobl fel pleifion a theuluoedd ac yn y blaen. Ac mae Angela am gyflwyno'r eitem ac yn unol ar mae'n y fideo i chwarae sy'n meddwl. Ac Angela fan hyn.
Diolch yn fawr. Bore da pawb. Thank you for allowing us to share this story around carpal tunnel syndrome treatments and a new ultrasound guided release system that we've been using. We've got two individuals giving feedback around this and the positive outcomes that they've experienced. So can we share the video? Thank you.
I had carpal tunnel in both of my hands. This was an industrial issue which I inherited from working using my hands as a mechanic in the aeronautical industry for 30 years. 5 years before I left my role, I started to experience pins and needles and numbness, which are common symptoms of carpal tunnel. I had severe pain during the night, and I had to hold down on my hand to alleviate the pain. At the time, I saw the doctor in work who said that I had nerve damage. It wasn't until I saw my own GP that I was referred to the hospital for nerve testing. When I attended my nerve testing appointment, I was referred urgently for carpal tunnel surgery. My right hand was done first. The waiting time for that to be done was 1.5 years. I then waited a further 6 months for my left hand to be done, and I don't feel that this took long at all. During the first surgery on my right hand, I was awake. The nurse and the surgeon were brilliant, and they made me feel really at ease. There was music playing, and the staff were really reassuring. I was out of surgery within 30 minutes, and then I was discharged home. It took 3 months for me to recover, and now my right hand has been completely cured. When my left hand was done, it was a much quicker process. I could move my hand 1.5 weeks after the surgery. I do still experience slight pain with my left hand, but I am being monitored on a regular basis for this. I wanted to highlight my positive experience for others who may have concerns about carpal tunnel surgery and who might be skeptical about having it done. My surgery has worked well on both occasions, and I am grateful for such a positive experience.
I've been having trouble for a few years. I was experiencing numbness in my hands, and I was having problems with pain at night. I was having increasing difficulties when reading a book, driving for long distances, and if I had been working with my hands a lot, I would suffer with terrible pain at night. It was confirmed that I had carpal tunnel and I was referred for the operation. I met the consultant surgeon, who was very pleasant, and confirmed that he could do the surgery and would like to operate sooner rather than later. My husband was undergoing treatment himself at the time, so I asked to delay the procedure as I needed to support him and be able to use my hands to drive him to his appointments. When I got back to the consultant to confirm that I would like to go ahead with the procedure, it was sorted out within a few weeks. I had all the information about the procedure given to me in advance, and I was also able to look things up online, which was helpful. I went for the surgery at Wrexham Minor Hospital. They weren't sure if I could have the new ultrasound-guided carpal tunnel surgery until they went in and had a look, but fortunately they were able to. I had local anaesthetic, which meant I was awake during the surgery. It lasted for about 20 minutes, and it was uncomfortable, but not painful. My hand really hurt afterwards, and I assumed that I wouldn't be able to sleep that night, but I had no pain or numbness overnight. I didn't even need to take a paracetamol. My recovery was quick. I had a plaster on the small cut overnight, and it didn't need anything else when it fell off. Also, because I'd had local anaesthetic and hadn't been put to sleep, I was able to leave the hospital straight after the surgery. If I'd have had the traditional surgery, I'd have been bandaged up for weeks. I was able to drive the next day, and although I took things easy for a week or so to be cautious, there was nothing I had to avoid. I've also had no pain since. I've got a small lump on my hand from the incision that was made, and a slight feeling of tenderness inside the heel of my hand when I press down on it, but it doesn't stop me from doing anything. The extreme pain and numbness I used to get day to day is not a problem anymore. I can now also sleep undisturbed all night. Having this surgery has made a big difference for me.
Diolch. I think it shows the innovations that are going on across the health board. We're able to provide shorter waiting times. We're able to save money and be more efficient, and we get a better patient experience for our patients coming through. There's a lot of work going across the health board at the moment, looking at how we can develop new techniques, how we can make sure we're implementing best practice. But in this area, we're leading the rest of Wales, which is really positive for us.
I'm not sure if the online translation is currently working. So I will try and use 2 languages in the meantime. Felly, diolch yn fawr iawn am hynny. Diddorol iawn. Angela, can I just ask you to explain about this type of procedure? We had some feedback from people who had got this procedure, and I'm particularly interested on the matter of the stay in hospital. If there was a stay in hospital, how long were they in hospital having the procedure itself? Do you know anything about that?
So I can identify if they went to theatre, then they would come into hospital into a either day case unit or to a hospital bed, depending on what their underlying conditions were.
Yeah.
So it might be that they were having a fairly straightforward procedure, but if they had underlying conditions such as cardiac issues or breathing issues, they may need to come in for an overnight stay to make sure they were ready for the treatment.
Yeah.
The time in theatre would be maybe prolonged. They may be waiting for their position on the list. And they may potentially be overtaken by other patients. Again, we would anticipate them to go home the same day from this, unless they had underlying conditions, which would mean an overnight stay, or if they had a reaction to their anaesthetic, which again might mean an overnight stay. So the fact that we're not utilising the main theatres releases that for utilisation in other procedures. The activity is done within a specialised room that is for that area, but it's within an outpatient setting.
Yeah.
And as identified, with no sedation, no anaesthetic, then it's actually just the procedure that's there. And it's very quick turnaround. As identified, it was less than 30 minutes. So it can be scheduled within a very short time frame. So that allows us to go through and make sure that we've got the appropriate people having the treatment in a timely way.
I was particularly interested in the time because I think it's a very good example of the ability in normal circumstances, if I can say that, where people can have a procedure. They come in the morning and they go home in the afternoon. And that's true of many procedures, not just this procedure. And the medical advancement means that people don't have to stay in hospital, people don't have to stay in a bed following a procedure as they did previously. And I think that's a really important message to take from this story and other evidence that we know about. But the other thing is particularly the innovation around this that has been highlighted, that is really something we can be proud of and glad of, and really grateful that we have clinicians who are looking for opportunities to do things differently and new ways of ensuring the better outcomes for patients. So that really is good news. Rhywun arall eisiau holi cwestiwn, dwi'n gwybod mae Carol eisiau deud rhywbeth mewn munud, a just checkio rhywun arall yn else. Gareth?
Yeah, just very briefly, yeah, really great, and shows how innovation can both be better for patients and save money, which I'm very keen on as chair. I just wanted to make the point that my esteemed colleague, Mike Larvin, at our last PFIG committee made the point that we don't have any it doesn't appear we have any systematized way of horizon scanning for technological change. And I just want to put a little note there that, I mean, obviously, I think we can rely on our clinicians to be knowing what's going on elsewhere, but having some sort of corporate knowledge of that would be ideal, really. So, yeah.
Carol?
Gareth and I couldn't attendance. It pieced me up really well because a bit later on, why this story was chosen today is because it fits with the core item that we'll be discussing about value and sustainability a little later. And Gareth, that systematic approach to knowing where best practice is currently, and that emergence of either technological or other developments really must be, you know, in our eye line in order to bring these things forward. And you're absolutely right. In very many of our specialties, our clinical colleagues are at the forefront of this already. How we spread and scale these things is a challenge, but also an opportunity for us. Why I was particularly struck with this story is that we've been moving over some time now from theatres. I was talking to somebody the other day. We were talking about 10 years ago, if you were having a hip replacement, you might have been in hospital for at least a week, if not longer. As we know, we've had presentations before. That can be, you know, as little as a day or just overnight now. And these are the same sort of things. So something that would have happened in a theatre has gone to a day case. Things that are happening in day case are now going to what's called MOPS, or an outpatient procedure. So, and it's providing real benefit on a number of fronts, really. One is it reduces the cost of care, and we must be mindful of the cost of care, balanced with the outcomes, and then, of course, the experience. And I think that shone through the story that we've had today. So it links to the strategic approach we're taking in the organisation about value and sustainability. I thought about the economic impact as well, of not having to take days and days off work, but being able to still be active as well.
Yeah, absolutely. A social and economic impact, very much the case as well. Rhywun arall eisiau codi cwestiwn neu sylw ar eitem yma? Nag oes gen checio i'r cyfieithu yn gweithio ar-lein, just checking if the online translation is working yet, or if we are still in limbo. It's a no. Right. I will try and use both languages to ensure that those who are following online are able to follow, and apologies for this technical problem. Ymlaen i adroddiad cadeirydd, yr eitem nesaf, eitem 25 neu 1.6, ag Mae'r adroddiad wrth gwrs yn y papurau, felly dwi ddim am ail adrodd, ond dwi eisiau tanlinellu un y ddau o bethau ysgolch yn dda, sydd dwi'n meddwl yn amserol. First thing I want to underline is the public accountability meeting that we had with government a week ago. That meeting was one of a series that the government hold with every health board in Wales. So it is within that context that the meeting was held. It was recorded, live streamed, I think, and is available if you wish to watch via the government website. I'd like to thank colleagues for the work preparing that meeting. I'd also like to thank government publicly and the Cabinet Secretary in particular for the way the meeting was conducted. And I think we come out of that meeting confirming the work we have to do and the challenges ahead, the expectation from government. So that was an important meeting, but I'm trying to see it within the wider context we have rather than just a one-off meeting. We have a lot of interaction with government as the Health Board in Special Measures, and that meeting was one really of series of meetings we have. Un o ddau bethau eraill I danlinellu. It is really good that we have an opportunity to recognise what staff do in this organisation. We all know that staff go the extra mile and ensure that people get the best possible care, and our existence is to ensure that we support that, ensure that we create the best context for that to happen. So we've got some award ceremonies that recognise people's long service and also the achievements. Some of you were at Benin Cymru, and some of you will know about the Long Service Awards, and it is remarkable the contribution people have made, not just to this health board, but to the NHS in general.
I'm muting now just to test the translation. Can you hear the translation now? I'm still testing the translation. Can you hear me now? Testing the translation. Okay, it must be my socket. I do apologise. Okay, lovely. Thank you. Okay, great.
We do that at our peril. It's really important that we take every opportunity to thank our staff, recognise what they do, and I know that we've got an ambition to do more around this space where we can thank our staff on a regular basis and recognise their achievements. Just
I just want to refer, before we conclude, to two matters that are quite interesting.
A little later about more enhanced care, and I talked about the point of care service. But I want to talk about how I came to learn of these developments.
I gather that the translation is now working online, so excellent stuff. I'll turn back to Welsh now, if I may. If it's not working, please do let me know. Thank you. We wanted to highlight the two matters raised in the report in relation to the support that is given to people out of hospital on Anglesey and the point of care service in Ysbyty Meilir Wrexham. The way I got to know about this is that people got in touch with me. People had listened to our board meeting in September when we'd discussed our intention to improve performance in emergency departments and to tackle the challenging situation facing us, and people working in the health board got in touch and told us that they thought they could help, and we welcomed that with open arms. And that told me something, that maybe there is an opportunity to ensure that staff do have the opportunity to tell us where there are opportunities to provide more support or to improve. The staff on the front line have the answers. Not always, but on occasion, they have a situation that is different. So if any matters arise, it demonstrates that staff felt that they could come to us to provide suggestions of what could be improved, and I'm very keen to be able to act in that way moving forward also. And to conclude, we had a visit, a great visit, Angela Russell and I, to the hospice in St Asaph some time ago. That was the first time that I'd visited. I know Russell has been before. It was the first time for me to visit, and I was very glad to see such an excellent resource. And I'm looking forward to working more and seeing that hospice as part of our strategy in this very important area in the future. I'll pause there. There is a list of some of the meetings that I've attended, and you're welcome if you want to raise any issues or ask a question. I know Billy would like to ask a question.
Mine isn't a question, it's just really more of a comment. But on the long service awards, there seems to have been a bit of a change with regard to the financial element without consultation with the trade unions. I have asked for it to go on the agenda of the People and Culture Committee, and my trade union colleagues are going to raise it with the local partnership forum as well.
Okay,
thank you.
Many thanks for that, and I'm sure there will be constructive discussions in both those meetings. What I do know is that the long service awards have historically had a financial gift attached to them, and that wasn't the case, I think, this time, and that probably reflects some of the financial pressures we're under to Health Board. But I do know that there's an effort to try and see what we can do for the future. So I know the team are looking to see how we can attract more support for the awards and the recognition element, and having a discussion, as I mentioned earlier, in the wider context of the whole opportunity to reward and thank staff for achievements and long service and so on. So that's something I think we can reflect on in those two forums you mentioned, and see how we can develop things for the future. So yeah, let's see what comes out of those discussions, but we recognise that we need to do that in conjunction with our trade union partners.
Yeah.
Diolch yn iawn. Unrhyw eisiau dweud rhywbeth, Carol?
Yeah, may I just, I'm sorry to go back to that issue. It was fantastic. I was able to be there myself. I had a great time. Teresa and I had a great time meeting colleagues, and it is really great. We did hear that feedback. I don't think it was related to the financial position of the health, but I think there was a technical charities issue. But we've had a look at it already. So Billy, I think we will be able to have, you know, really constructive conversations to find the right way through, because I think there could be a different interpretation of how we can deploy funds. So I just wanted to be even more reassuring as chair and add that in.
Thank you.
Diolch yn iawn. Unrhyw un arall eisiau sylw cwestiwn? Na, diolch.
Any further comments? No.
Diolch. Dau adroddiad arall yn adran yma.
Two further reports. Chief Exec and then Vice Chair. Carol, turning to you first.
Thanks very much for to all colleagues actually who helped us to prepare for the public accountability meeting. I do want to start with that, as the chair did as well. Quite a lot of effort went into that, and I hope that we were able to try to get across the work that's been going on right the way through the organisation and a range of improvements that have been put forward. So we will, because of the very nature of the meeting, it was focusing on some of our biggest challenges, make sure that staff can fully appreciate our thanks to them for all of the work that has been going on. We'll try to make that happen over the coming weeks with Helen's help as well. There are a couple of things to note in relation to Welsh Government. We will be discussing finance a little bit later on, but the draft budget has been announced, and it does look a very challenging outlook. I felt that beyond my report, I would just flag that for us as we head into what will be the next 3-year planning round. And I know that as a group of chief executives want to engage very actively with government around some of the options and choices that we may need to consider as we move through. Clearly, the budget is still draft, and there's quite a lot of water to go under that bridge. But given the UK budget was yesterday, I thought I would mention that. The other thing that didn't quite get into the report, but I would like to add, is that earlier this week, the first meeting of the Mental Health Oversight and Development Group was held, and thanks to senior colleagues who joined that meeting. And that was one of the commitments that the board had made previously in establishing the sort of successor to some of the work that we had following the Royal College, and we will bring forward a more substantive report to the next meeting. Work is ongoing with Foundations for the Future, and we are anticipating that just post-Christmas a consultation process will take place. There's a lot of work going on to get to the final stages before we can set that in train, and the board will be involved in those decisions in due course. A note on some of the big things that have happened since the last meeting. We were underway with a radiology informatics system, the RIS programme, and it was a first for Wales that we implemented here in North Wales. It is a particularly significant milestone for us in introducing this, because it brings together 3 different legacy systems all into one, plus other new modalities, as they're called, apparently, to give the modern tools for the staff. I particularly wanted to draw that colleagues' attention, because this was a really challenging implementation, and staff really did go above and beyond to implement this. It was very important that we did stick to the implementation timeframe as best as we can, or as we could, because we've got a whole range of other digital implementations for the rest of the year. But I'm hoping that just by my very mentioning of it reminds people of the ambition that we have set as a board in relation to digital developments. And then just finally, for any staff watching, and I know staff do watch, I'd like to make a plug for the staff survey and how important it is to hear colleagues' feedback. We have taken all sorts of different approaches this year in the attempt to encourage more people to take a little bit of time to share that feedback, which does make a difference to the actions that we take to improve the working environment. So, yeah.
Thank you, Carol, for the report and for her work. Any questions or comments, please? Urfa, first of all. Thank you.
pressure on urgent and emergency care. And I think it's fantastic that you were able to walk around and meet staff there. I just wondered if you were able to share any learning from that discussion. You know, what's their morale like? How are they feeling under the pressure? It's definitely Welsh Government.
Thanks, sir. But yeah, I go reasonably regularly, and in fact, I've been in my sort of theatre blues without doing clinical practice after just to you know, we've got a sense of the environment. We've got 3 very busy district general hospitals, and a lot of the focus about the pressure on urgent emergency care is focused in those places. But of course, we all know that it's a whole pathway issue, and we must remember that. What struck me, and you know, Tamina's got a really comprehensive report with Clara and Angela a bit later on, but what struck me was the ED department seems to be the meeting place for all sorts of processes that happen. Whether that's GP planned admissions, for example, GP admissions, whether that's people who are perhaps struggling to get a GP appointment and think, yeah, they can come to the front door of the ED, or whether that's people who have come to the department by the traditional routes of ambulance as well. That is a very congested department, not because there's a whole host more people coming to the department, but because we're finding it difficult to move people out of the department into the rest of the hospital. I think that's a concept and an understanding that's pretty widespread now. But what struck me from my conversations with colleagues is the impact that having sort of patients in the wrong place in their journey is having on being able to provide emergency department care. So, for example, the availability of literally physical space to see people, the clinic rooms to start off with, the change in the staff's need to provide care to patients who are there for longer than 4 hours, who are there sometimes extended, and we know that that can be days. They're providing a different level of care, and the desire to get back to providing what they call ED care. So they were some of the big things that struck me. Under the item a little bit later on, we will discuss what action's been taken since the last meeting and what actions can be taken already. But I get a strong sense of commitment to make improvement on the ground, and a strong sense that actually there's quite a bit of influence that the local hospital teams have, and we need to support them. And then from the board level, executive and board level, support, encouragement and check and challenge will also help us on that improvement. But people working very hard with all the very best of intention for great patient care, and that is half of the challenge measured, I think, with the level of motivation for improvement.
Right, thank you, Karen.
Definitely are. And what we know is that staff, they are very clear that the circumstances they face are not the circumstances they wish to work in. So it's not just about patients, but it's about our staff as well. Staff remind us that these circumstances where there's the huge pressure and huge numbers coming into emergency departments, and the challenge that creates, staff feel really challenged in those circumstances, and they feel that they can't work at their best under such circumstances. So that's what we face, and I think that's what we see when we visit emergency departments and we speak with them. But we'll have a further discussion later on. But Jane, rhywbeth ar adroddiad Carol.
Very quick plug, but also in Carol's report, it mentions the staff vaccination.
Yep.
Really important. We're just under 40% now, so we are succeeded last year's target, but the target that we have nationally is 75%. So still some way to go. Yep. We are also seeing an early and quite steep rise in flu, both in staff and in the community. And particularly with this strain this year, we've seen quite a number of cases in children. So just a real plug for both people watching this from our communities and for staff. to get vaccinated. The vaccine is very effective this year in combating that. So we just need to keep that push on to get as many people vaccinated as possible.
Thank you for those comments. Any further comments? Thank you to Carol then for that report. Next, the Vice Chair, Gareth.
I just wanted to make one point really, and happy to answer any questions. I think the report hopefully speaks for itself, and I hope I don't come over as too opinionated, but it is a personal view. But I do want to stress there's lots of, from the Welsh Government and the NHS Performance and Improvement, there are some really welcome things happening in the mental health space, which I've talked about in previous reports, and which we are now in the forefront, I think, of taking forward. But also in terms of the thinking about primary and community care. But the point I want to make is one that is in the paper, which is we often talk about the importance of partnership with other agencies, and particularly other statutory agencies, and I in no way want to undermine that. It is absolutely vital. But we also have to think that we work in partnership with other parts of the health system, which we do not imply that we... I got in trouble at a recent meeting for talking about contractors, because I'm not in any way suggesting that they aren't, that our primary care contractors aren't absolutely dedicated to improving the health of the population and coping with disease, but they are quasi-independent, and we have to take them with us. And I just detect a little bit, not in this health board, I hasten to add, but in the wider debate of Wales, that although it's really positive to be focusing on this, there's a little bit about, well, how can we design a system to make it better without really engaging with those people who are absolutely essential? And just to remind us, most of us now in this know, but if you look at the percentage of interactions with patients, it's 90% are in primary care. So if we don't take the people who are delivering primary care, not just the GPs, but community pharmacists with us, then we are setting ourselves up to fail. So that's my plea of the month.
Thank you, Gareth, for that report. Appreciate any comments or questions. Rhian first, and then Eartha. Just one thing.
One thing that out at me when you were talking about the peer review of health board clusters, that there was significant frustration about the inability of the system to mainstream successful initiatives piloted within clusters. So, I mean, that itself is significant, isn't it? But I think it's got wider implications than that. We do a lot of projects, lots of projects happen here, there and everywhere, often with project funding. And then when funding comes to an end, even if it's successful, it just goes into a black hole and is never seen again. So I just think the principle of how we get to mainstream things that we know that work, there's no easy answer, I get that, but I just found it was interesting that it came up in a peer group as well.
Yeah, I couldn't agree more, really.
Eartha?
Again, David, I'm really interested in the point in the link, the community by design, the paper there, and there's a point about clusters not having a lot of opportunity to influence planning around delivery of hospital-based services closer to communities. Now, obviously, that is a goal that we're all working towards, and I don't know who knows the answer to this, but I am wondering first, how are clusters or GPs involved with the planning that we engage in? And my second question really is, I believe we've got a primary care board, and I realise actually I know very little about that, so I don't know, is there an opportunity for us to learn more about what that does? So and I don't know who would be answering this question,
So, one question about the planning. Maybe Gareth, do you want to answer and then point towards?
So Carol is very happily with herself, but Carol and Paolo, I think, are in the best place to answer that.
But what I'm going to talk about the planning, and then the primary care board. Let's discover.
So just to be clear, the primary care board is within the executive structure. So it's really kind of reports through the executive, I think is right. And I just would underline, well, from the points of both of you, that and not to undermine anything Power might say, that however we formally think that we consult with the clusters, that the perception out there when I go to visit GP practices or community pharmacies is that all this is done to them rather than with them. And you know, I'm not saying that's an accurate perception, but that is definitely
Just dod y Paolo I mewn ar yr ochr cynllunio.
I'll bring Paolo in about planning and an opportunity to influence our work. Thank you, Chair.
I think it's fair to say, building on what Gareth said, that whilst we make attempts to try and make sure that our GPs and our clusters are involved in our organisation and in fact system-wide planning approach, we've got a lot further to go on that. The integrated planning framework that is on the agenda for today references the way in which we should do that in best practice. But there is an opportunity every year to make those connections in the way that we form those plans. The primary care board that was referenced as the executive-led structure is our conduit to reach out to them as part of our planning process. But our clinical services plan that we've got coming up, as you know, as part of our broader strategic development, is our real opportunity to get this right. And I think some of our health and wellbeing hubs, which is also on the agenda for today, there's real opportunity for all of primary and community care to come together in a different way and really crack the nut of trying to move some of the services which are traditionally in acute hospitals into the community and closer to home. So that I suppose is the way in which we interface in a number of different ways. But I'd just like to acknowledge there's a lot of improvement to make in that space.
Carol, any comment on that? And I might bring you in.
Just to say that completely agree with Gareth. I mean, I think perception is reality as well. So and there's been a sense of at the events we have with the Bevan Commission on the street. I was talking to some colleagues from primary care who basically saying to me, "Oh, Carol, can you stop all this top-down stuff? And really, we want to develop things from the grassroots." And I think that's entirely right. So I think a lot more effort for us as a health board, no matter what happens sort of around us, to achieve that. If I could put one point of emphasis is for us not to silo primary and community care from the system, the whole system. And I've been involved in some really very good discussions of late about the design of systems that help patient care, not just about the institutions that are primary care and secondary care. So there's a subtle emphasis there on us not overly segmenting that. That said, there is a primary care board, and we'll see through some of the papers consideration of having a community by design type major change programme into next year, which I think will help our endeavour in this.
Absolutely.
In hugely, really. Yeah.
Diolch yn iawn. Mike?
Diolch, Chair. One of the health board's challenges is that when a GP can't carry on, a practice can't carry on, we directly manage those practices. I think we've 14, 15, 12, I think, quite a substantial number. Just following on from your point, Carol, it's a challenge for us to have to take on that work, but is it not also an opportunity for us to pilot and experiment across patients travel from one sector to another. They don't understand why things happen. It's an opportunity for this board maybe to experiment a little.
Yes. And this is the Gareth and I have often had actually, that there isn't one perfect model. The managed practice issue has often come about because practices have been fragile and they've had real challenges, and that's why we've had to step in. But the opportunity, and I'll just draw attention to West End practice in Conway. I've got quite a lot of contact with that practice, and they are a managed practice. They have really been able, once they got to a tipping point of the right numbers of staff in place, they've really been able to take practice forward, particularly in the long-term conditions, and being much more proactive. Because primary care has tended to being forced into a reactive on-the-day service, whereas I think there's a lot of benefit for patients, but also for clinicians about that proactive positive. So they have been able to do more of that, and it's evidenced in their admission rate to hospital. So.
Diolch yn iawn. Mae drafodaeth ar yr elfen yna o gwaith gwallt.
That discussion maybe suggests an opportunity for a broader discussion in this board. We'll need to look at services in the community at some point. I think that would be appreciated. All of our work and all the way we work in a way that welcomes suggestions and offers from people who provide services wherever they are in the health board. That's an ambition, bias, and something that we should remember going about our work. Thank you to Gareth. Next item, the strategic item. This is the big change, and our focus is on value and sustainability.
I'm turning to you to begin with, and then Russell will come in later, but over to you to begin with, Clara. Diolch yn iawn.
Diolch, bore da, Clara Day, cyfarwydd pob methu gof weithredol. So, I wanted to talk to you a little bit this morning with Russell about value-based healthcare. Now, fundamentally, this is about spending well, but to break that down a little bit, I would say it's how do we use our resources to make sure we get our best outcomes for our people. And this is now, of course, fundamental to all NHS organisations, given the current financial climate that we all face. It might seem odd that it's the medical director talking about this, but of course, the clinicians are the major spenders within our organisation. So that partnership between finance and clinicians is particularly important in this. And in fact, it's enshrined within the GMC duties of a doctor to think about stewardship also. So the cost of healthcare is rising, and a lot of the time, that is actually good news. People are living longer, and actually we're getting more and more effective treatments coming through, and that in itself sometimes does increase cost. But we do have limited resources. So when I talk about using our resources for best outcomes, I think it's important to define both of those terms as well. So resources, sometimes we think about that just as money, buying stuff. But of course, our resources are much broader than that. Our main expenditure will be on our staff. So we need to make sure that our staff are working as effectively as they can. But we have many more resources. So our patients, of course, are a major resource user within this. Of course, we need to make sure that we're using their time well, but also helping empower patients to do what they can do, and indeed using community assets where possible. And when I talk about outcomes, we're very good at process measures in the NHS, but what when we talk about outcomes fundamentally is increasing life expectancy and healthy life expectancy. That's what I mean by outcomes. And of course, the patient-specific, patient-reported outcomes as well. So we've already heard this morning about, it's important that people can get back to work quickly after treatment, that actually, if you're waiting a long time for treatment, that means that you are not living your life as you would like to as well. So the patient-reported outcomes are important, as well as those kind of what I would call harder health outcomes. And so fundamentally, this is about using the evidence base we have to make sure that we are spending well across all of our healthcare services. And this is about whole pathways of care. And I'll come back to this in a little bit, because sometimes we chunk it down into, how do we use theatres well, for instance, that is important. But this is about how we are working right from preventing disease all the way to effective end of life care. And I will expand on that a little bit further, but I'm going to hand to Russell in the first instance, just to talk about what we've been doing locally. So I wonder if we can go to the next slide, please.
Yeah, thank you, Claire. So I'll just talk you through a few principles, if I may, as well, and just take the opportunity. So as mentioned, value-based healthcare, it's really a response to the concerns on widening health inequalities, making sure outcomes are the focus rather than the numbers of operations, the numbers of interactions. So how are we improving the health of the local population? The concept aligns with the core principle, so a healthier Wales, of course, so improved population health, well-being, better quality of care as a real focus, and then obviously there's that sustainability of resources that comes in. And value-based healthcare and value and sustainability have become quite synonymous with each other as we move forward. Value and sustainability through a national model has already gathered quite a lot of momentum. What we're doing as a health board is mirroring that model effectively. And the good news about doing it in that way is we can actually look at best practice across all of the health boards, and we can have similarities of where the opportunity exists within each key work theme. That national model is set up within the pack, and you can see there it's quite small, but what we've done is effectively put those various category headers in. We've mirrored those with directors' responsibility within the various areas that make absolutely appropriate sense for that to happen. And some examples of that are, I'll take you through just a few if I may. So medicines management, biosimilars, taking advantage of the fact that branded drugs and non-branded are commercially far cheaper and deliver the exact same results. So where we can, using that commercial opportunity to then recycle that resource to be able to improve healthcare across the wider population. Continuing healthcare, a real focus. When Angela's looking after this area, but making sure that when patients are assessed for their home care needs following discharge from lengths of stay or operations, that care is the right care on a continuum basis. Those assessments undertaken in that hospital environment may prove to be a different need or a different requirement once they are discharged and back in a familiar environment. So making sure all of that package is appropriate for the individuals, and of course resources are expended in the right way. There are workforce models. We are looking at different models effectively of how we serve our population. People are requiring reablement. We're looking at how we administer services across the organisation and what those different staff groups require and how we can support that sickness. So obviously individuals, when they're unwell and waiting for treatment, they're not at work or potentially not at work and certainly not giving where they could be contributions. And so if we can get that healthier position back into and a more timely access to treatment, obviously that will improve sickness rates and also productivity. Looking at non-pay, I specifically, this project, I'm also on the national work stream for non-pay. So purchasing the same thing for cheaper, standardisation of products though. It's not just about money, it's about training individuals to use the same products in the same way and making that easier and more difficult for us to have variation in output because we've got that standardisation of practice. And then following that theme all the way through. So how do we look after our environments, you know, from the products we use to disinfect floor base, right the way up through the hospital. We are a massive employer, but we're also a massive interactions with our local economy and suppliers within our local economy for goods and services. And so we can help and support and get economies of scale, but also build that local connection as well to support our local community with local procurement. So those themes are really embedded within these work streams. This is a national model as well. What we're doing here is driving that forward within the organisation. I would say, I can see Neil's in the audience. I would just reference Neil if I may. Neil Windsor is programme director for this. He's done a fabulous job on driving that forward, and I'm really grateful to see him in the audience and grateful for the contributions made as well, Chair. So if I may just mention him. And then at this point, if I may, I'll hand back to Clara and we'll talk a little bit about clinical variation as well, where this sits under Clara's remit.
Thank you. So you can see there's two columns in the previous slide that doesn't really matter because they're really the same thing about clinical variation and value-based healthcare. And even in my short time of being in the health board, I'm seeing things that are associated where the clinicians are taking ideas and doing this. We've already heard, for instance, this morning about the carpal tunnel programme. The chair has talked about elements associated with trying to avoid admissions for emergency care. Within the paper, there's an example about prehabilitation, which is essentially for those patients who are going to undergo surgery, making sure they are as well as possible beforehand, so correcting, issues associated with diabetes, hypertension, etc. Those two, both the carpal tunnel and the prehabilitation, are quite hospital-based, aren't they? But equally, we had the Chief Medical Officer up here just 2 or 3 weeks ago, and we showcased some work associated with community assessment days, where our AHP colleagues are really working out in the community to help with MSK, muscle conditions, and equally looking at the South Denbighshire cluster, where their general practice is working really closely with community and indeed across into mental health to give the most value for those patients. Now, and I've emphasised that particularly because when we start to talk about value-based healthcare, sometimes we come back to GERT, which is very important, but again tends to segment specific pieces of work in a hospital setting. That is important, and it is important for us to look at some of those pathways. And for instance, the Clandid No Help is very helpful for us to make sure that we're implementing those and we're doing standardisation of prostheses equally with that. But I just want to take you through one other pathway, that's a very common one for us to just unpick exactly what I mean by this. And I'm going to use stroke, which is, of course, a devastating condition. We're quite good at revascularization of heart, but we don't put quite so much focus around revascularization of brain. And if we're thinking about value in this pathway, we go right to the beginning. What is it that we do to support our population to remain well, to remain active, to not smoke? How do we then move to secondary prevention? So how do we pick up the risk factors that are associated with stroke, high blood pressure, high cholesterol, irregular heartbeats, and then treat them to standards? So we treat blood pressure, we blood thin for atrial fibrillation. That in itself will provide enormous value in the prevention of a stroke. If someone then does suffer a stroke, how do we make sure that they get the best possible care as quickly as possible? So how do we pick it up when they come into emergency department? Make sure that they get their CT scan within the amount of time so that we can then do the clot-busting treatment if we're able to do so. How do we then make sure they get into the correct ward with the correct staff to be able to make sure that they're getting care from that multidisciplinary team when they're in hospital? How do we make sure that we're then able to discharge them into the community as quickly as possible to make sure that they then have ongoing rehabilitation in that and they have their medical care needs? And we're then using all our community assets to make sure that we're supporting people who may have come home with a life-changing diagnosis. So that for me is that value across that entire pathway. And it comes back to our 10-year strategy and our clinical services plan about weaving into those whole pathway approaches and thinking about training our clinicians to think about not just the pathway and the people in front of them, which we are very good at making sure that we get the best care for the person in front of us, but thinking about how we are stewards of our resources and making sure we're using those well across the entire pathways. We've talked about innovation and making sure that we are picking that up and then expanding that, and I think that is important. But I would just emphasise what I don't want value-based healthcare to be a separate project. This is about everything that we do. So there are things that we innovate and we pick up and we do, but we've got to then carefully look at those and say, which are the projects that we're doing that we really add value and we want to sponsor to expand whilst we're looking at these whole pathway approaches for stewardship as a whole. So there's various elements in the next slide about how we might support the staff and population associated with this, but I'm looking forward to working with colleagues and weaving it into the clinical services plan over the next few years.
Great, diolch yn fawr iawn. Bydd 'na dipyn o sylwadau yn gwybod.
A few comments, I know.
Claire, I think this is your first official meeting. You've been in board meetings previously, and we've had an opportunity to welcome you, but thank you very much for that presentation and this official meeting. We can also repeat that process to you as well. Also, as you said, Russell, diolch yn fawr, Neil, for all the work you've been doing. We've had a few brief exchanges when we passed each other in the Mayor in Wrexham or Court in St Asaph occasionally as well. So I've known all about Neil's great enthusiasm for the work. So diolch yn fawr am hynny. Before inviting others in, I'm going to pose 1 or 2 questions myself, and then we'll gather all the questions from maybe Claire or Russell to answer. The question I'm going to ask is going to be the question I ask every time. What is the impact for our population, and how will we see that? What difference is it going to make to people in our communities and people accessing or attempting to access our services? And when, and the other associated question is, you've really underlined the need for this to be a whole health board approach. And perhaps you could share a little bit more about, okay, how is that going to happen successfully? And again, when can we see the difference? And those are 2 really difficult questions, but really important ones, I think, to the success of this work. And I think it's all about how our staff can help deliver, and then the difference to our population. We've got a lot of people who want to. Claire, first, please.
Diolch, David. Thank you, Clara, and obviously the report really interesting and really good to see the programme structure and to, I guess, understand what this programme can deliver for us as a health board. Thank you very much. One specific question, which is, why are we not using this approach around the changes we need to make in urgent and emergency care? The report does say it's outside the scope of the programme, and I don't understand why, if this is such a valuable way of understanding how we might improve, change things, embed value for money, sustainability. Then the other one is more of a governance question. So which part of our governance structure will be keeping closer oversight of this programme? Because there'll be, I guess, a level of, I guess it's kind of building on David's question. So there'll be a level of change that we'll want to monitor and see. Some at a very high governance level here, which I think we'll perhaps get to see through things like our reporting on KPI, the IMTPs, etc. But then I think there'll be a kind of a further level of oversight that we'll need to have at committee level. So it's interesting to understand where that might sit. Yes.
So we'll gather a few questions and then welcome response. Phyllis, over to you next.
In the spirit of pursuing sustainable and efficient use of resources, I wondered if the board has assurance yet of other opportunities that or pathways that exist for saving on resources that may not be directly related to clinical delivery, but are still important overall in achieving improved patient outcome, improving cost efficiency.
Yeah, good question. Rhywun arall isio codi Rhian nesa?
Any further questions? Rhian next.
It was just what really struck me in the paper, in the context, was the fact that possibly 20% of all interventions are at best ineffective, and what was the bit then, and at worst wasteful. Well, that's such a huge opportunity. If that's really the case, it's a huge opportunity, isn't it, to use best practice interventions and so on. So that was just a comment. But there's also a bit, when you're talking about financial savings, you have to look at the impact on patients and the quality of care, and that any savings shouldn't be an arbitrary cut. And I'm just a tiny bit concerned that when we're trying to effect savings at this time that we're maybe being arbitrary, that by imposing a blanket, you know, savings of 1% or whatever it is, it's going across purposes to what we'd be trying to do in the longer term. And I'm sure that's accepted. You have to do things in the short term because you have to. But those are just a few things that struck me.
Diolch yn iawn. Please, Diolch.
More of a comment really, similar to what others have raised, but I wondered if there is a missed opportunity in terms of women's services, and I think we're often overlooking some of the potential savings that can be made, some of the opportunities in terms of outcomes, and I think if we're not careful and we don't address some of the very serious issues that are currently going on, not just in BCU but in maternity services, that's going to have a huge impact for our planned care later on. We have this, as a population level, we have a huge potential for gynae issues in the future, and that, you know, we already know in terms of the waiting lists and the, you know, the kind of lack of control we have over that currently. And I just think I wanted to raise it because maternity very often misses out on focus, you know, kind of up to board level really.
Yeah. Paul.
Yeah, taking a total system approach has to be the way to go both for the patient and for the organisation as well. But it doesn't just happen. It's got to be properly funded because you're going to need people for oversight and all the rest of it. And I just wonder if you've actually budgeted for that as we're moving forward, because there will be a high initial cost to make the savings overall.
Question. Jane, question?
It's more a comment and partly addressing some of your. So first of all, I think it's really important for us that we actually look at a population level, because the danger when you look at this and you look at very focused ways that you can actually increase inequalities. And also you may miss those groups that are most likely to benefit. And actually, I'll just come back to women and cardiovascular. Women, the evidence shows, are less likely to be to get access to cardiovascular interventions. They are less likely to get the more intensive cardiovascular interventions. They actually get poor outcomes. That's a big part of the population. So it's really important. And sometimes when you do the population analysis, it can actually change your thinking about where you would want to concentrate to maximise the impact on your in terms of where you would focus getting that value. So I think that's a really the second in terms of outcomes. And I think this is where, again, there is often an assumption that it takes a long time to demonstrate outcomes, and it doesn't. And I'm going to use the cardiovascular again. So if you if you reduce the number of people smoking, we'll see an impact on health, on morbidity indicators within 18 months. If we maximise the management of hypertension, so the management of high blood pressure, within 9 months, you will see a reduction in people having episodes of stroke, and within 18 months, you will see a reduction in major cardiovascular. And again, outcomes can be much more varied. They need to be evidence-based. Again, patient-reported outcomes is not a soft measure. Pain scores are actually a patient-reported outcome, but there is a huge amount of science and evidence about how you interpret and how you use pain scores. And in fact, they're the most important indicator of whether hip operations have been a success or not in terms of the outcome for the patient. So all of those, I think, are really important, but we do have real opportunities. And I'd like to just reassure you that a lot of this, we should be able to demonstrate the impact on our population, and particularly if we are doing that evaluation, not just at the global level, but in particular focusing on areas like our deprived population, parts of the population we know are not getting poor outcomes. Then actually a lot of this is not about 5 years hence. Actually, you can start to see impact in quite short periods of time.
So, sorry, let me see you there.
It's all really positive. I think a whole system approach has to be the way, but it strikes me that we can't do this in a vacuum, and we have partnership working across the health board, but I wonder whether partnership working also needs to be a key theme amongst this, because all the pre-hospital, all the pre-medicalisation stuff, we can shout and jump up and down as much as we want about people eating better and not smoking, etc. But the reality is that those people who need that messaging the most aren't engaged with the health board and health service in the way that they perhaps should be. But a variety of different reasons. The population that we serve is so vastly different from area to area that it seems like a real opportunity to engage with other partners across the region and push out this message, so it is a proper full service whole community approach, which would hopefully serve better outcomes. And it might mean an initial higher input, I suppose a short-term pain for longer-term, more sustainable gain, perhaps. But
Chris, those comments. So quite a few comments and questions as well. Maybe ask Clara to reflect and give some general answers and help us with the direction of the work going forward, please. And maybe Pam can talk about some of the governance that Claire has raised in terms of where is this going to report to and monitoring progress and so on. Yeah.
Thank you. As you say, I might need some help from friends along the way. This one, so I'll start. So, Jane started to talk about impact of the population, and I think part of this is we must be measuring that very clearly. We've got programmes here that started this year. There is a small amount of money, which Russell will know more than me, to be able to support some of getting these projects going. And we've heard already some of the impacts associated with, for instance, the carpal tunnel one. But one of the things that we're perhaps not so good generally in the NHS is measuring impact and thinking about and starting and stopping things that are not necessarily of the impact that is required. So I think that that really, whilst I'm talking about a whole health board approach and programme approach with this, what the opportunity is, having just come into this and thinking about how what we add into this variation bit, is for us to think over the next few weeks which 2 or 3 pathways we want to have this approach with, and try to, as we're working through other pathways, have that rigour to think about resource allocation as well as outcomes, and experiment a little bit along the way as to how that might feel. Now, there are some well-defined methodologies associated with GERT, which are kind of almost no-brainers associated with that, but we do also need to be really clear what the benefit has been. If we're looking at whole pathway approaches, we probably just need to take one to begin with and think through how we best map that. I'd agree completely that there's the community elements to factor in, and there's all the kind of primary prevention elements. And Paolo, I might want some help with this here as well, and as we're moving into the clinical services plan, to be making that part of that as well. Claire, you made a very good point around urgency and emergency care. And again, one of the things that we're always trying to do is part of our day jobs, of course, is think about investment versus outcome as well as process and output. And that to some extent has this approach already, but needs that kind of separate thought around which are the high impact interventions, because that's what we're talking about, isn't it? Where's your biggest bang for your buck associated with patient outcome in this? With regards to the 20% ineffective and wasteful, I think that that's a challenging figure for us, isn't it? It's actually to unpick some of that is incredibly difficult, because it's what's on the input as individuals to do essentially to help prevent healthcare, and how do we then, I don't like the word left shift, but I'm going to use it, how do we make sure that we then are putting things in ahead of pathways to make sure that we're getting better value further on. That somehow is about that ineffective and wasteful element, as well as the things that we're doing every day to make sure that we are doing things that are of evidence base. The governance I will need some help with, and I don't know whether Russ, you wanted to comment on the kind of investment associated with this to get this going.
Yeah, over to you, Russ, before bringing Pam in, and then Carol will to make a comment.
Yeah, deal, Chair. So yeah, I'd echo all those comments, obviously from Clara. I think we view this as an improvement programme. This is not a financial programme. This is around how we improve for our local population, and that's in the wider context. So I think we will take that challenge actually as to why UEC is not part of this programme, and maybe that widenism becomes part of it as we progress forwards. What it means for us in terms of that improvement, we do need, and it does challenge us actually to start looking at patient-related outcome measures, developing metrics that evidence value and improvement in that access or that delivery to our local population. We're quite good at measuring the numbers of patients who've gone through the system, but we're not really clear about what that value looks like. And that's part of the challenge in this programme, actually, in terms of reporting some of those metrics through and building that through into the quality committee and also our performance teams. We do have a joint chair model, and we do operate groups. So myself and Clara, joint chair of our own sustainability forum, and that is attended by senior leadership within the health board. We report those positions back through the integrated performance executive delivery group, and that features back through committee, but it will feature through committee through performance, finance, and information governance. I think there's a need for us to widen those metrics so that we the aspects of the committee, and we probably need to move it more away from this performance and finance. We tend to talk about the financial gain as opposed to the improvement. So I think there's a challenge for us there to build that through as we go on reporting. For me, in terms of other services, so we will look at our conversation after about women. So always grateful for opportunities for efficiencies and productivity, of course. We are already seeing some of that come through. So the challenge around how do we get benefits from this area, these work streams as well. We can focus in where resources are being committed above what we need to, where we can get better outcomes for our population through lower resource allocation being required. That makes us move into an allocative efficiency model. So we're not asking every service to do a percentage saving, which I think comes back to some of the conversation from Rianne. We're actually saying we need to deliver the optimum care for our local population. And by the way, that makes us more financially efficient. And that gives us more resource, of course, to then target for investment into future services. And in terms of supporting the programme itself, there is a ring-fence fund for value-based healthcare, and we use those funds to target various projects. We have got some of those projects operating as we are. I think we need to be assessing where that resource is being placed and then targeting that, as Clara rightly says, 2 or 3 key pathways, and how are we going to get behind those pathways, understand how we know what success looks like from a wider spectrum than a financial lens, and then report that through the various committees and support. So I think it's quite an exciting moment for the programme. We do have the infrastructure in place now at the oversight. We now need to start pushing on in terms of those individual elements and the improvement reporting through the appropriate subcommittees of the FPO.
Diolch yn iawn. Carol, efo sylwadau Lloyd, dwi'n meddwl.
Yeah. A couple of quick points. It's really good that we have these sort of longer items, I think, at the board where we can get into a bit more detail. So 5 key things I want to say. One relates to scale and spread. So the comment that you made earlier, actually, Leah, is that how do we take good things and then sort of hardwire them in? I think that's something that we have to pay real attention to, deliberative attention to how we will do that as we go forward. My second point is really about patient and patient activation. It talks to Chris's point really about partnerships, but the partnership with the patient, the person, is really important and very interested in shared decision making. We talk with people about the options and the outcomes. They will make different choices the more informed that they are. And just because we could do an intervention doesn't mean we should do an intervention. So that 20%, and some of the studies were particularly elderly, perhaps, who offered a surgical procedure. When they understand what it entails and the potential gain for them, they will choose not to do that. And that's the right thing to do for people to fully understand. I talk about this, I don't want to let Neil down by not mentioning the three-legged stool that I always talk about, which is the cost of care is an important thing for us to think about, the total cost of it. Because if we spend too much on a single product, and the outcomes and the experience are not what we should have, that is a poor use of very valuable resources that we could be putting into better delivery. So total cost of care, outcomes and experience, we've got to have measures for all three of those. I agree with Phyllis's question. It's a great question about thinking about this beyond clinical practice, actually valuing everything. We've got to simplify and streamline our processes in the organisation. It's the one big thing that we get feedback on. Everything's too hard to do. So I think that in itself will bring value, but also the opportunity around AI, which scares lots of people. But the reality is we use AI every day, and more so in our own lives as well. And then hardwiring value into our strategy and our clinical services plan by design. But that will require a culture and a social movement and really teams. So it's about what we write on the page, but it's more about the people and the leadership and the engagement that drives success.
If we are just on the governance question that Claire raised, are we monitoring progress and so on?
Yeah, we are about Eric. So the primary committee for oversight of this is the Board Finance and Information Governance Committee. We actually received a report earlier. The last meeting. That's where the oversight would be. Like with all committees, though, there is the opportunity to be considered in other areas because of obviously what these things in the spring from pathways elements that actually might be appropriate for the quality and safety committee. So I think that's the route thing. This is a reminder, this is one of the 4 major programmes that the board approved. So we're doing these on a rotation basis. So I think that's where it will sit. But with the opportunity, if there's any matters which the performance committee consider will be relevant for quality and safety or other committees, so then it'll be through that route. Yeah.
Diolch yn iawn. And with the progress, just a sort of prior warning, it would be good to see impact population-wise. Now that's more long-term, but it will reflect, I think, the discussion this morning about what the board will want to see with this really important work. Diolch yn iawn am y drafodaeth yna.
Thank you for that discussion and all of the work that has been tied to that. Very grateful. Everyone happy to accept the content of that report and the progress and the way that the work will develop in the future? Everyone happy? Excellent. This brings us almost to 11 o'clock, so we'll take a break of 10 minutes and we'll reconvene at 10 past. Thank you.
Rwy'n yn ôl at ni yma I Neuadd Reichel Prifysgol Bangor.
Warm welcome back to the board meeting for Better Cadwaladr Health Board. We're moving to item 2.3, the item on planning. Paolo will lead the discussion and the papers in relation to this matter, and we'll take it in two parts, if we may. First of all, the general paper that looks at the planning and the planning framework, and then moving on to the item about the community hospital in Tywyn. That will make more sense, I think, rather than trying to throw everything into one discussion. Over to you, Paolo. Thank you.
Just to pre-warn members, from a translation perspective, I'll do a brief introduction in Welsh for each of my papers, and then I'll switch to English, just so you can get your things in your ears correctly.
So good morning. I'm the Operational Director for Transformation and Strategic Planning. I will talk to you through the main points in relation to the integrated framework that is coming for approval by the Health Board and has been based by the maturity for planning by Welsh Government.
This framework is essentially a rewrite of the previous one written in September 2023 in order to make sure we focus on growing organisation capability in planning and not just focus on the development of an integrated medium-term plan, which is our 3-year plan as an organisation. It sets out the approach to integrated, transparent planning across the organisation and importantly with partners. This is really important in the context of the Foundation for the Future programme, which is developing our new operating model because it will help the organisation guide through the next 2 years. It's one of a growing number of interlinked organisational frameworks, such as the performance framework, the risk management framework, that are already in existence, the decision-making and prioritisation, the workforce management frameworks, which are in development. This iteration of the integrated planning framework has been informed not only by the special measures independent review of planning, which was held in 23-24, but also a more recent Welsh Government planning maturity matrix self-assessment. That planning maturity matrix self-assessment is really an assessment against 6 domains, each of those with a number of themes beneath them and being assigned a score out of 5. Members can see the details within the paper of the results of that, but the scores range between a 2, which is badged as an early progress, and a 3, which is initial vigilance. The main components of the integrated planning framework include the types of plans, the life cycle of plans, approach to things like business cases, roles and responsibility, but also linkages to other important organisational approaches for things like value-based healthcare, which we heard about earlier, and the quality management system. And really importantly, it builds a view on the organisational capability and skills development approach going forwards. So this framework really represents a significant step forward to the organisation's maturity in planning, and it builds on the progress that we've been making in this space, in particular developing the Health Board's first ever financially balanced integrated medium-term plan last year. So I'll leave it there, and I'll happy to take any questions. Happy to do a question.
Diolch yn iawn, Paolo.
Thank you, Paolo. Eartha first and then Gareth. Then Claire, please.
It's a really interesting document and it's good to see it early. That's really nice. And hopefully we're going to work a bit more on it together as a board too. My question really, I acknowledge there are references to things like evidence-based, realistic and affordable care, but should we be more strongly referencing community by design, which paper we've already seen, and also the value-based approach to care or healthcare? Should this paper be more strongly referencing and bringing the approaches together? So that's my question.
Hold a moment whilst we get some comments from others. First of all, Gareth.
Welcome the fact we had a good discussion at the PPHP committee. I'm not trying to remember what the full version is. And I just wanted to pay tribute to Paolo and colleagues for having taken on board quite a lot of that discussion. It shows that the committee system does work a lot of the time. But there's just one sort of small point I wanted to make. It's quite important, I think. So on the section on business cases, it makes the point that it says it is important to note, however, that investment is not always necessary in order to make positive change. I absolutely agree with that. But I think this could even be strengthened because this is about business cases to say because managers are pretty disempowered in this organisation, or either willingly or otherwise. So, make a stronger pitch. You should first consider as a manager whether you can reprioritise within what you do in your team to achieve things that you think are important. And I just think making that would be a really valuable point.
Yeah, just to support that, if I may, Gareth, is that we've got to be careful we don't get into a culture of business cases and no action until there's a business case. So, business case suggests that you're going to do something extraordinary that needs support elsewhere, but actually most of our work is around mainstream. It should be able to do that without
reprioritization.
And reprioritization also of people and resources. So absolutely. So that's a really important point to make, I think. Claire, you wanted to raise a point. As chair of the Population Partnership Committee.
The names of the title. Thanks,
Been
Gareth.
that sort of week, I'm afraid.
I know. Thanks, Gareth, because actually he said some of the things I was going to, so I will be able to brief. You'll be glad to hear. But I think it's really useful in this paper to see the progress and the journey that we've been on around planning. And it is fair to say, Eartha, that I think almost every PBHP committee we have a planning item, and we're I guess at a governance level much closer now to, I guess, what's becoming, which is how it should be, a more iterative process around planning. It isn't that we're doing something once a year to produce some documents to submit to other people or set our KPIs. Planning is all about how we develop, change and improve services to the population of North Wales, and how we provide great environments for our staff to work in and all of that. So I wondered though whether there was a recommendation missing in this item, because the I forget what it's called now, but the maturity assessment matrix, we're asked by Welsh Government to make that assessment, and I think it would be helpful if the board approved that. And we're not being asked to do that today. So I do agree that I think 2s and 3s are probably where we are. So we've made good progress, but I think we still have a journey to go on to be scoring ourselves at the kind of optimum. But I think it would be useful if the board was asked to approve that. And I'm sure, Pam, we could add in an extra recommendation if colleagues are happy to do that.
Okay. Unrhyw un arall cyn na? Felly, Paolo, ymateb i'r cwestiwn i'r sylwadau, please.
Diolch yn fawr, Paolo.
Paolo, would you like to respond? Thank you for all your comments.
Just on Eartha's point, I think value-based healthcare, community by design, some of the kind of quality management side of things are real absolute integral elements of how we need to do planning going forward. There's some bits drawn out through, and we'll take a look at how strongly those are come through, and whether we can look at anything in the full package of guidance we send out, because one of the points that I'd make is this is an overarching framework, and beneath it hang a number of more detailed guidance. So we've got opportunity to put a lot more emphasis in some of those areas, but absolutely the points you made are really important. In terms of business cases, I think some of the points raised there, it's well rehearsed. I think that we have too many business cases. We feel like we need a business case for everything. And that perhaps is a bit of history in terms of how people have come about. But this framework points to a specific issue there around the reprioritisation within your own gift and budget management. We're going to be doing more work going forward as an organisation and the foundations on accountability and autonomy and what within people's gifts in relation to things like budget management and the like. And of course, we will have more work ongoing under that foundations on business cases as a specific business process. And that will both have renewed governance as well as processes and guidance to support it. So those points will be made very, very clear within those aspects. And finally, I'm glad Claire was recognising the shift to continuous planning is the mantra that we've been trying to get to, and not making the planning a once a year event, but continually doing that. And yes, I'd agree, you know, Welsh Government had asked us for a board approved submission on the planning maturity matrix. So I think it's right that we do that. So if Dan can accommodate that, we'll take that approach.
Diolch yn iawn. Felly, ydyn ni'n hapus I gadarnhau.
Are we therefore happy to agree?
You suggested is that we approve the maturity matrix in order. Pawb yn hapus I wneud hynny?
Everyone happy to do so? Thank you very much. And thank you for all of that work. Next item. Thank you, Chair. This paper notes the current situation and the next steps to be recommended for the new processes in the community hospital at Tywyn.
Temporary closure of W ward in April 2023 due to workforce shortages and reliance on agency staff triggered a review of sustainable service options for the hospital. As I'm sure members are aware, that Tywyn serves a rural population and that there are complexities for the needs of the local area, and making sure that we've got sufficient access to those local services is critical. Since the closure, there have been new services that have been introduced, including expanding inpatient capacity at Dolgella Hospital, the Tuag Adref community service, a treatment room, as well as a reopened minor injuries unit and wellbeing facilities. Despite recruitment efforts, reopening the inpatient ward has remained challenging due to workforce resilience and sustainability concerns, particularly within the context of the newly introduced services. We've held 2 balanced room sessions where we're engaging with the community and stakeholders and interested parties, and they've been really important as part of the co-design and appraisal of options. 5 options were initially considered, and following a weighted scoring against the criteria there, 3 were shortlisted, which were maintaining current services without beds, developing Tywyn as a community health and wellbeing hub, and using W ward as a day treatment centre alongside community-based provision. Options to reopen the inpatient beds haven't been prioritised by the balanced room scoring process due to the value being placed on the new services currently in place, as well as sustainability and workforce risk. Llais have advised that the absence of inpatient beds in the shortlisted options constitutes a substantial service change requiring formal public consultation under Welsh Government guidance. The paper does provide a bit of an overview of the legislation that requires the Health Board to have due regard to the representations made by Llais relating to service change, but ultimately is a Health Board decision to take. Should the Health Board take the decision to proceed to consultation, given the pre-election period, this consultation wouldn't commence until after May 2026 elections. However, preparatory work, including all the engagement, impact assessments and development of the consultation materials, etc., will be undertaken in the interim. I would just like to say that we really recognise that the uncertainty continued for some time in this space. And we want to be clear that our priority is to absolutely ensure the best possible care and services for the whole population. We've heard the strength of feeling within the community about the future of the services, and we want to make sure that all the scenarios are fully explored and developed before any decisions are made. We also want to express our sincere thanks to the staff who continue to care for the local community, often in new and flexible ways, which is greatly appreciated. So the board is asked to note the shortlisted options and to approve the recommendation to proceed with a formal consultation on the future services at Tywyn Community Hospital following this. And happy to take any questions, happy to seek unrhyw cwestiwn.
Diolch yn iawn. Cyn ni symud ymlaen, I think I'm going to turn to Jeff at Llais, because you referenced the word Llais as and Llais is guidance to us, and we have responded to that. So I know Jeff Llais has been involved over a number of years on this. So please, if you want to make any comments regarding
thank you, Chairman. Paulo is correct. It is a substantial service change. And not only does it meet that definition, it is also something of great public concern locally. And for that reason, Llais has recommended a full consultation within the guidance, and the gold standard for that is 12 weeks.
Yeah.
I think a good start has been made in relation to the balance rooms, and they flushed out some issues. But there is local concern that reopening the hospital and preferably retaining the new services is not in the options list. And for that reason, I think it's even more important that you build on what you've done with the balance rooms, but go out and give all local people the chance to find. That has started already. There have been meetings with young people's groups, with young mums, with local community councils. That can continue right up until the pre-election period. And that would be, I think, a very useful thing to do, and may inform your thinking and widen the options available. Clyce has been attending some of those, a selection of those, so we can hear for ourselves what people are saying. One of the things I've seen on social media is that there was to be a public inquiry into healthcare in South Meirionydd, and that Clyce's action in recommending a 12-week consultation has prevented that. Can I be clear that there is no public inquiry has been either announced, arranged, or mooted by the Welsh Government? This is a full consultation under all the guidance that relates to NHS consultation issued by Welsh Government. And I say a good start has been made with the balance room, but because of the issues involved, it needs to be much wider. And there is a perhaps a third balance room, and then certainly out to much wider consultation. Take the opportunity for that extended period until the end of March to engage with people, then a full consultation post-election within the guidance offered by Welsh Government, and I think then everyone will have the opportunity to speak. Thank you.
Thank you very much, Jeff. That's good to know, and thanks to you and the team for all the work they've done in supporting the work in that area. Great question. So at the
questions or comments, I'll turn to Gareth and then Shia.
How much I think we appreciate the work that Clyce does, not just in this field, in terms of, you know, they punch well above their weight, and they're really, like our auditors, very valuable to us, even or perhaps precisely because of their independence. I want to keep this short because basically we're short of time, but also because I recognise we're only part of the way down a very long road with the formal consultation. But I do want to express my unease about one point, which is fairly fundamental, which is one of the bases on which we've carried out the exercise so far is that we must work within the same cost envelope. Now, as Chair of Performance and Finance, I'm very well aware of the budgetary pressures of the organisation. But that is really why we've ended up without a shortlisted option that includes the beds, because people were told very clearly, well, you can either have the beds or you can have the alternative, you know, the different services that have been piloted during the time that the beds have been closed. Now, and I understand that that is basically, it's the financial envelope that's the determinant of that, because it's not really about the people, because they're different people doing those services, and it's certainly not about the space. So, as I said, and I'm the last person to say the finances are important, but to gain credibility with the population, we need to demonstrate that the amount of money that is in that envelope is genuinely proportionate to the population, given their rurality, and that basically they are no worse off already than average, if there is such a thing as an average, because I think that's where a lot of the criticism comes from. You're saying, you know, we're underserved, and you're saying we have to continue to be underserved, whichever option we have. And unless we are really confident that we can demonstrate that those people are not underserved by the amount of resources that are invested there compared to other positions, then we're on a weak position, really. So I'd like to use some of the time between now and the formal consultation to make sure we're clear about that financial position.
Gareth, Rhian, Nessa?
It's just a very small point. I'm just concerned about the length of time this is. We can't go to, if we go to formal consultation post-May, and then you've got however many weeks of consultation, it's another year's gone by, isn't it, without resolution? And I think that level of uncertainty isn't helpful to anybody. There's no solution if we have to follow that route. I'm just questioning, do we have to follow that route?
Yeah. Okay, we'll come back to that. Emma?
Yeah, sorry, just I wonder whether we can make reference within the consultation in terms of the maternity provision, because obviously that we used to provide maternity care.
Yeah.
And it's just giving, I think, the kind of population there the ability to say, and it may well turn out that it's not a sustainable option, and that links back to what Gareth was saying, but I do think they need the opportunity, particularly given that the quality statement for maternity and services says we have to offer 4 places of birth. Yeah. Which would be a freestanding, and at the current time we're having to commission outside of the health board for that.
Yeah, good point. And something also to ensure we highlight is the relationship with Bronglais in our health board, the neighbouring health board, of course, where many people in this area access their services. Dyfed, ti nesa.
Diolch. Dwi'n meddwl cytuno bod Rhian.
I agree with Rhian. That waiting is unfortunate because the community want a decision and want to see. And what the consultation will do is will enable us to hear the voices of the community, because there are different voices in the community, which is important to note. We often hear the voice that is shouted the most, but I know that there are different views within the community as well. And the consultation is an opportunity to do so. We have to go to a statutory review because of the suggestion made. And once we do so, we have to follow the statutory rules, which means 12 weeks. I agree that this matter has, some would suggest, been dragging on too long, but we're in this place we are, and it's important that we give time and space. What I would say, there is a period, if we approve this, there is an opportunity before consultation. And one plea I have is to argue, agree, disagree, but to do so based on facts. We've already heard that there are incorrect facts being spread, and I understand people's feelings, but it's a plea to use facts and to keep the benefits of the public and the population foremost in everything that we do. Carol, with comments before we conclude.
Thanks very much, and really helpful discussion, because there's no two ways about this. We will, and it's our responsibility to develop services for the whole region, and just thinking about the integrated planning framework that we've just discussed, we reference the strategy and the clinical services plan. We have to be really effective at dealing with these sorts of both challenges and opportunities. So it's really important to get the approach right. Transparency and openness about facts being really part of that, and gathering as many voices as possible, different voices, diverse points, is important, so that we can feel confident we have heard the wide range of views on the future opportunities. I think there is something specific for people in rural areas around their access to healthcare. And we've discussed this morning, we touched on it, not a formal agenda item, but the community by design work is a really important opportunity for us over the next few years to bring more services closer to where people are. So nothing is static, it will be developing, is the point that I'd like to make. And we've also talked about outcomes, experience and cost, and we do have to consider all of those things in every service that we're looking at. On Rhian's point, we have had lots of discussion about the process. We would have wanted to move more swiftly.
because people have said, you know, we need to get to a point where we know what's happening. But process is important, and I guess as quickly as possible to be effective. And so just reflecting on the advice that we've had from Llais, that's really the aim. We'll continue to move forward. We do have the election to manage. I don't quite know what we do with elections, but there we go. In order that we don't get caught up in that, but I think this is a real priority on timeframes as well here for us. So very, very helpful discussion, I think. Thanks, Paolo and Helen, particularly, as well as Tamina for the work that's going on.
Diolch yn iawn. Unrhyw beth I ychwanegu, Paolo, cyn ni gloi ar hwn?
Na, dwi'n meddwl, wedi dod i fyny efo'r sgwrs.
I think the conversations will follow. Thank you very much. Is everyone happy with the recommendations?
Fel sail unrhyw ymgynghoriad a bod ni yn mynd I ymgynghoriad.
And that we go to a statutory after the Senedd elections. That we will carry on with discussions in the meantime.
Iawn, diolch yn iawn am hynny. Ymlaen at eitem 2.4, hybiau iechyd a llesiant.
And then health and wellbeing paper next. Before we turn to that, I just want to check that we've covered everything.
Iawn, got it. Ymlaen, eitem 2.4,
2.4, health and wellbeing hubs. Paolo, again, please. Thank you. Thank you, Chair. This is the third and final paper from me you'll be pleased to hear. I'll talk you through the important points in the report, in the strategic report for the health and wellbeing hubs.
Faces significant health challenges, falling health life expectancy, rising long-term conditions and persistent health inequalities. People are living longer, often in poor health, and many communities struggle to access high quality care. The health and wellbeing hubs offer part of the solution for this. These hubs will bring together health, social care, wellbeing services, all under one roof, making care more accessible, integrated and proactive. They'll help move care closer to home, reduce pressure on hospitals and support prevention and early intervention. The paper sets out a strategic approach for developing these hubs, aligning with the Welsh Government's A Healthier Wales vision and our own developing 10-year strategy and clinical services plan. It moves beyond just the individual projects in isolation and considers how the hubs fit together into a wider model of care for North Wales. Part of the strategic approach is making sure that we manage all the hubs in all the hub projects in a single programme with a single responsible officer, and it makes sure that we're aligning all the hub locations and services with the population health data and areas of deprivation, which is something of a work in progress. We'll also make sure we seek to integrate the approach to the hubs with other assets like the community hospitals and digital care solutions. So these hubs and the builds within them is part of the whole system approach to primary and community care. This does align to the Welsh Government's strategic intent in relation to integrated community care services, which we've heard a bit in the earlier agenda items today. And that really aims to have more integrated services. We balance the care market, deliver children's care reform, and ensure that we have effective long-term planning, as well as making sure that there is proper system-wide collaboration. All of this having an outcome-focused investment. So board members are asked to endorse the strategic approach to health and wellbeing hubs across North Wales, support further work to assess the population need and the optimal hub locations, and to note the importance of integrating hubs into the wider 10-year strategy and clinical services plan work. Na'n cymryd unrhyw cwestiwn ar hwnna?
Diolch yn iawn. Sylwadau, na'i droi at Paul gynta, wedyn Gareth, Rhian, ac Claire, y bore yna. Paul.
Yeah, I think this is a very good approach, and taking a systems approach, as I've said before, it's the right way of doing it. But I don't think you can do it without looking at transport. And transport has to be a critical part of the system when you're looking at hubs for the community.
Diolch yn iawn. just on that, I did have an opportunity to attend the Welsh Government's North Wales Cabinet meeting some weeks ago in Llandudno, and there was a presentation of the regional transport plan. And one of the reasons I attended that was to make the very point you have, is the link between public transport and access to things like wellbeing, surgeries and so on. Really, really important for our population, particularly in rural areas. So, important point with me. Gareth, ti nesa.
Yeah, so this is it's a really lucid and well drafted paper. I really welcome that. But we do need to recognise that we also live in a real world which is messier. So while I absolutely agree that we need to have one programme that's managed coherently, we also need to recognise that we're dependent on something I talked about earlier about the buy-in of different partners, and both partners external and internal to the health system. Couple of other points that and related to that really is one. So just to pick up a couple of the principles which are really good, but hubs are designed to be close to where people live, reducing travel barriers and improving convenience. Yes, but remember that the situation is very, very different in urban communities to rural ones. And what we mustn't do through this is end up in a situation where our urban centres have shiny new wonderful multi-purpose hubs, and there is nothing in rural areas apart from really, really inadequate facilities, as I've witnessed in Wynebower, for example. So we just need to be sensitive to that geographical variation, I think. And a smaller point, but perhaps an equally important one, is there's a bit of an assumption in here that just because you co-locate services, that there's a single pathway, and that's not necessarily true. So I know that Paolo knows this, so I'm sorry, Paolo, but you know, there is the work about actually how do teams work? Are the systems integrated, both reception systems, like physical systems and digital systems? So we need to, you know, as I said, we don't want just buildings with, you know, oh no, sorry, you need to go over there before you even talk about that. So that's it. And the very final point, which is just in the detail of the paper, I just think it's a real shame that with the Conwy one, and I know it's not as mature as some others, but we've returned money to the Welsh Government. And quite substantial so. And I don't think I really understand why we couldn't have continued to do the sort of scoping and planning. I don't mean a formal business case, but scoping and planning to underpin that, even if the actual invitation, I obviously you'd have to update it. But it just, you know, I'm sure we all be great to giving money back to the Welsh Government, and it just seems a bit of a shame. But I don't need a long discussion of that. Just
no. Just that point, but an important point. Trian.
First of all, it was the same point as Gareth, that co-location does not mean integration. And I've seen that in practice in various places. Yes, they're under the same roof, but they don't talk to each other. And in a previous life, dealing with pool budgets, they don't work because of the governance route and the different ways that funding happens. So in an ideal world, lovely. But in the real world, it's going to be so difficult to get a truly integrated provision. So it's just a marker, really. Yes, the paper's good, the principles are fine, but it's going to take a huge amount of work for any integration, real, true integration and partnership to happen.
I have a few comments and then I'll come to Dyfed. I think it is important that the correct framework is in place. To emphasise, we do have hubs already, and we have a tendency in the public sector to say we need to do something new without reflecting on what has already been achieved. So I do think we should look at what hubs we have. There are examples, especially in the northeast. How do these look? What have they appeared? So that we can see what that investment has made. Second point, we are in a situation where we want to strategically plan, but hand in hand with that, we have inherited plans that have been on the cards for a decade and more. And we have to tackle those. We can't just delay and hope that they will be a part of our strategic plans. If we've approved action already, we have to move forward with this. And I know that we're hoping to have a new we have to face the reality. A few more points. I'll pause afterwards. Yes, it's to do with changing the way that we offer health and well-being services. It's important. But it's also to do with buildings. Sometimes we say it's not to do with building, but sometimes it is, because of the condition of our estate. And if we go around the north and see the condition of some of our estate, we are putting people in circumstances that are inappropriate to staff and patients. Sometimes it is to do with changing the building, not to be shy about it. I would like to see more about the opportunity to work in partnership with others, especially the community and third sector. I think there is an opportunity to improve that. Let's be open to be a part of a scheme that other people lead on. We don't have to always build. We can sometimes be a part of the public sector. For instance, if a local authority are thinking of building a leisure centre, say, or something similar, why can't we look at opportunities to co-locate? It's a matter of working as Rhian has indicated. I think there are opportunities to co-locate, not just because we're building a new building, but because others have developments that we can be a part of as well. So to be aware of those developments as time and money remains scarce. Capital is challenging. So the aspiration to see the sector working together makes us look at how finance will work. And finally, with apologies, I must say the process that we have to follow from a business case to another business case, an outline business case, and something else is crazy. And one plea I would make to the government is to make that process simpler and easier. I know we have to follow the big Treasury Green Book. I appreciate that. But at the time when we need investing in our communities, the opportunities economically, I would imagine that the government would want to do something to hasten the process. Of course, it has to be clear, and of course we have to show value for money, but it takes years. Costs are increasing and the public are missing out. So a plea to the government to try and get some kind of influence to make the process simpler and something that we can achieve quicker. I'll come to Dyfed. The Vice Chair and the Chair have already referred to the importance of working in partnership. There is a practical element to that, where the plans come to a point where if we go to planning permission, In local government, for instance, when they're co-located, there is an element of regeneration to these schemes, and there is funding that could come in then. And it's important. As the chair has indicated, some of these things we've inherited and will make a huge difference, not just for health, but how people look at what we do and how we can move forward. So it's important looking for. I know there are things in Bangor where we're looking at regeneration and Westminster funding as well, and Holyhead as well. It's not just one source. Claire and Eartha.
David. So I really welcome this paper, because I think if we're honest, we know, don't we, that many of these have been developed in a kind of opportunistic or incremental way so far. So it's good that we've got a strategic approach. I really like the fact that we've got different models, recognising that there'll be different needs in different communities. And the paper does reference that we will be doing a review of the current ones against population needs. I'm assuming that's less about whether they should go ahead and more about confirming what the range of services and the model needs to be in those localities. I didn't want perhaps members of the public to read the paper today and think that we may be. But I think the other thing that was really critical for me is this is a really long-term programme. So I agree with the Doveds around how they're funded, whose buildings they are, how we get resources from different places. But just looking at if you like, the map was really helpful, but it only covers a small part of our geography, doesn't it? So there will be lots of areas we'll want to have a look at what's needed, what the models should be. We're already into kind of almost 10 years from now with assuming these all happen and they happen in this time frame. So I think it's just for us to recognise as a board that this is part of quite a long-term change, because you can read this paper and get really quite excited about the potential it brings, but this is going to take a long time to deliver the kind of full range of things we'd like to see in lots of activities. But really support the recommendations, and thank you, Jill, for the paper.
Yes, thank you, Paolo, for bringing this together. Obviously, as Claire says, it is a long-term project. I just wanted to make a comment on transport, obviously, which is absolutely crucial to people accessing services, and bring some insight from a research paper that I read. So at the moment, our transport routes are based on traditional understandings of need, which generally is people from the top, so the hills need to get into the centre. So they're all going like that. And some people do need that, and quite often in terms of sex, that's men that need that. Women need different things. They need services that link different places so they can link up with different family. And what's made me remember this is obviously rural areas struggle to access health services, but even urban areas, if I have to get a bus into Wrexham and out again, so the traditional buses go in and there is nothing. So if we ever get a central discussion about transport, I just wonder if we can remember that insight regarding looking at not always using traditional routes or traditional understanding of pathways that are needed. Thank you.
Yep, good point. Diolch yn iawn. Paolo, dwi'n meddwl. Carol gynta, wedyn Paolo. Neu Paolo gynta, wedyn Carol.
Who's going to steal whose thunder? That's what we're going to do. So no, very useful comments and perspectives, and I think that's exactly why we're doing this paper. These things have sprung up organically and individually, if you like, and we're trying to make sure that we bring it all together. Yeah. And in some instances, put our foot on the ball, use sporting analogy temporarily, just to make sure that as they all come together, they make sense as they stand today. Not to delay things until we've got a full clinical services plan, but just as that sensible checkpoint that all those things work. And that, of course, will give us that bridge the gap to what will be our full clinical services plan, where a lot of the comments around the transport links will be taken into consideration when we think about where things should be on the map. But expect Claire, that, you know, the map that you referred to, having many more things on it as to what the full picture looked like over the 10, 15, 20, whatever the time frame might be. So I think that's really useful. The comment was made that even though it's not all about buildings, the buildings are important. I think that is absolutely vital. I think Stuart and team should be thanked massively for the work that they've done in moving these things forward. There's been innovative solutions that have been found in a number of these areas, not least Royal Alex. And what we're trying to do really is not to say that the building isn't important. It's just the building shouldn't be the starting point of the consideration. The starting point should be the need, and then the service, and then the build should cater to those two things. The co-location point, I think, is really well made. I do subscribe to having people physically together. Does break down some barriers, but it won't break down all barriers. So the physical and kind of digital elements to that, as well as making sure that the government and the money going in the right direction are really important. And I particularly like the point around being open to other people leading things as well. As we get into the clinical services plan, we need to kind of go in with our heads up on those types of opportunities, because as we're collecting together things that already exist, that we are already leading, then of course we just persist with that kind of mode of working. But the clinical services plan gives us an opportunity to take a radically different approach with some of those things and open up to many more opportunities. So we'll certainly be adding that to the list of things to consider in that space.
Carol?
Yeah, very briefly, and thanks, Paolo. This was an attempt to try and pull things together from the past, the present, but with an eye on the future as well. So I think I called it a strategic wrapper, just to try to do that. And I think it's really important, Gareth's point, you know, there were two funds. I've been around long enough to remember two funds. One was the Primary Care Development Fund, which was really about the cases of primary care practice estate, and it sort of got rolled into the IRCF, and that's been a bit of a challenge for us really, because if we think, you mentioned one, but there were others, where simply it's more on the estate replacement side rather than the whole, you know, singing and dancing. Some of the most recent discussions with government, this will really recognising that, how that translates into the level of flexibility they can give, we'll see. But, you know, they've said, well, if it is literally an estate reproduction, replacement, just say that. So I think we can, that's a welcome development, I think. On the timelines for development, so I've been really struck by, since I've been here, a lot of these projects have been a very long time in a pipeline that don't seem to have had a real rationale for why they've taken so long. You know, last 4 weeks we approved the Royal Alex development, which I think had been 10 or 15 years. I'm told that some of these other ones are really long standing. So I tried to grab hold of those and then push them along. But I think anything we start has got to start well in the future and be really, you know, be very clear about the time frames. We should also be careful not to announce things too early. We've got all the ducks lined up on it, because it does raise expectation and then disappoints people that it takes so long. And then my final point really was around the development of these services as being agile, and the buildings needing to be agile, our infrastructure needing to be agile. The community by design future models will help us with that. And not all care will be physically face-to-face as well. More digital care will come. But it's important that we can try to take healthcare to where people are. So if they are on the high street, or if they are in the school, or wherever they are, we feature that as well. So thanks for the support for the paper and all the work that's gone on around this. It feels like an important step forward for it.
Diolch yn iawn. Diolch I bawb sydd bod yn llwm ar gwaith.
Thank you to everyone who's been tied to that work. Everyone happy to approve? We'll move on. We look forward to seeing progress and development. Everyone happy? Just to note that we are running about half an hour behind, and I've caused some of that, so I apologise for that, but we'll try and catch up if we can. Right, the next item, 2.5, the annual report. If I'm correct, this has been to the right committee, Claire. I think it's been to the committee that you're chairing and has received attention there. So Jane, to present an overview, please.
So, in many ways, this report links into a lot of the debate that we've had today about different aspects of health. It is an attempt to move away from what often is a very deficit-based discussion about health and the causes of ill health, to try and move the focus to how do we build health, how do we keep people healthy, recognising that the NHS really deals with the consequences when that fails. And only 20% of what generates improved health outcomes is delivered by the NHS. And that is a consequence not just for the sustainability of health services, but it has major societal and economic consequences that we are seeing in terms of the loss of people from the workforce, about the fracture of communities and the sustainability of communities, and the viability in North Wales of some of our communities going forward. So the focus is this time is very much on creating asset-based approaches, which is about creating that community of organisations across North Wales. So the Health Board is a very important component of that, but not the only one. And about how do we together, working together with a range of organisations and particularly with communities. I think, and this is probably hasn't come out from the debate, but one thing I would like to highlight, a lot of what we're talking about in all these things requires a different approach in terms of how we work with communities. We need to build on the assets of communities. We need to design, develop and implement with communities, because this is not going to just be about resource that sits in statutory organisations. A lot of the capability and real ability to make change happen exists within our community, individuals, families, and collectively as communities. And we need to harness that, because it can have a bigger impact on health than anything any single statutory organisation can do. But statutory organisations have the capability to create the environment and the societal building blocks that are going to make it easier for people within our communities to work with us to get that improvement in health and keep people healthy. So we are talking about 4 ambitions: to build strong foundations, particularly focused on the moment, and this has been to the Regional Partnership Board and also as part of the Regional Partnership Board, and thank you to Clice. I got also the opportunity to talk about why this is so important in terms of what's helping in health, in terms of the healthy and resilient communities, and why it is so important to focus on those asset-based approaches in communities. Secondly, about that real focus on communities, about what does consequent healthy place, and we'll touch a bit about that in the next debate as well, and about how we build health across the system. Out of that, the Regional Partnership Board has agreed that it wants to sign up to move forward to really try and address the marmot agenda. And in fact, I've got a conversation in a couple of weeks' time with Welsh Government about what that could mean in terms of Wales, North Wales being part of the work around the Marmot Nation that Welsh Government want to see. It is also, we are trying to make sure that feeds into the work that is happening through the children's RPB around how do we build health up from the start of life. And I think a really good conversation about that need for much more collaborative approaches to building health across the system, and moving from a conversation which is deficit. So one of the conversations was, let's stop talking about prevention and start talking about things that are actually much more about how do we enable people, how do we make health at the centre of what we're trying to do. that's the
Diolch yn iawn. Claire, as I mentioned, I think you had a brief discussion and
We did.
Yeah.
There was a presentation Jane gave to us at the meeting. It's a lovely report. I think it reads really well. I think it's well written, and you can't argue against the journey it's proposing that we need to take. And I know Jane always reminds me that this is her statutory duty, it's her report. But I guess my question is perhaps to Paola, to Carol and all of us, which is how the recommendations within here work across to our 3-year plan, our 10-year strategy. Yes, there's quite a lot of work going on at the moment around through the RPB and partners around developing our whole approach around, I call it Well North Wales, the role of anchor institutions, etc. But to own this as a health board, we just need to be really clear about how the place that this has within. Otherwise, Jane might write another lovely report next year, and it's kind of where does that? So I guess that's kind of my biggest question. And then the other one is just that
I did plant that question.
as the probably biggest anchor institution in North Wales with 20,000 employees, I think at some point, and whether we need to do that through committee first, and BPHP might be a good place, we need to understand what that would mean for us, i.e. are we already an amazing one and we can lead the way and show our best practice to others, or are we on a journey ourselves in terms of being a really positive role model and anchor institution around some of this work? So, diolch.
Good point. Diolch yn iawn. Unrhyw un arall isio sylweddau? To add? Teresa, rwy'n gawn.
Dim ond sylw byr os gai, Cadeirydd. O'n i mor falch.
Only a brief comment. I was so pleased that the report talks about the 5 ways to well-being. As we talk more about mental health and well-being as well, this is for our population, but for our staff. So I was so pleased to see that. I know there is a focus about families and the importance for young people, but that's for a range of young people, and it's something for us to work on. I think that will help us to move forward. So just a quick comment, and thank you for the report.
Anything to analyse, Jane?
So there are some us in this, and this is, so for me, there are key ones. Are we as a health board committed around the Marmot agenda, are we going to help deliver that? And I think that's one. I think the 5 ways, how do we build it's 5 ways to well-being? We're talking about outcomes. That well-being is probably, in keeping people healthy, one of the most important. Towards the end of life, well-being is probably more important than a lot of the medical interventions in keeping people able to function and able to maintain their life. So some of this, I would like us to be really committed as an anchor organisation, and Helen and my team are trying to develop that sort of proposals to have a really strong offer, and maybe that we should be bringing to the committee, Claire. But absolutely, I think it's fundamental that we, as the largest anchor organisation with the largest workforce, absolutely need to be committed to how we can build these blocks, because we can do a whole range from transport to how we use our estate to how we support our workforce in improving, and all our workforce are members of the communities, and we want those communities to thrive. So if we help our workforce thrive, we help our communities thrive.
Diolch yn iawn. Nawn ni nodi hynna I gyd, ag Pam, just question ynglyn.
Thank you. We'll note all of that, and just a question, Pam, in relation to the development of this work, and to what committee does this work report, and how do we ensure progress? Thank you, Pam.
I was just looking at the recommendations in the report and just wondered, is there a piece of work which the executive committee would take back and then report back through to PPHP? So I think that's the alignment there that you are still seeking, Jane, in relation to the strategy going forward. So just feel that would help. Well, we can report through that committee as part of our ongoing progress.
Okay, great. Yes, that's very helpful. Just checking. Chair of the Committee, hapus.
Hapus iawn.
Diolch yn iawn.
Very happy,
So,
thank you.
pawb yn hapus felly?
Everyone then happy to approve the report and the next steps. And the intention to ensure that we get an overview of the progress and monitor the work. Everyone happy? Thank you, and thank you for the work. Can I also thank Public Health, who are doing great work in this area? Some are here today. Thank you for that work. Excellent. You've heard today a number of strategies where this is central, and the challenge that it's given a prominent place to ensure the best outcomes for the population. So thank you for your presence today. On to the next item, 2.6, the Charter for Healthy Travel, and a request to sign this.
Yes, and again, I want to thank all the people who worked on this, both the last report and in fact, this has been a real development opportunity for one of our trainees. And it links to the last report because physical inactivity is one of the biggest modifiable risk factors, and it's one of the key building blocks of creating good health. And in fact, in the report, it says the Healthy Travel Charter is a way in which organisations across North Wales can deliver that. And in fact, all our 3PS, our public service boards, have adopted the Healthy Travel Charter, and is a key element of their work about how do they bring organisations together with the different responsibilities to maximise the ability to create that healthy travel agenda. So that's all I'm going to say, but Stuart, because it sits under Stuart, may just want to say a brief bit about the work and what it delivers for the Health Board.
Yeah, thanks, Jane and Dia. I think it is a really good news story. Although it's got Jane and my name on the paper, all credit really goes to Matt York, who's a speciality registrar in public health, who's with us today. And if we get any questions, I may well defer, if it's acceptable, Chair, to Matt to respond. As Jane has alluded, the benefits of being physically active are well known and yield many health and well-being benefits. The Healthy Travel Charter is 15 commitments, and they're in Appendix 1, which is on page 8. And we already do many of these, and I'm just going to give a few examples, but we haven't signed the Healthy Travel Charter, and we are the only health board in Wales not with them signing it. At the present time, we do not anticipate there will be any cost implications attached to the 15 items, and if they are, they will be brought as separate business cases through our governance for approval. And where possible, we're going to amalgamate works in some of the larger schemes, projects and programmes, such as, for instance, the adult and older person mental health unit, where we may well end up having to provide secure cycle storage as part of planning conditions. Just to give you a few examples, item 2 relates to the promotion of communications and the messages to the public on healthy travel. We do much of that at the moment. Item 4 is aligning travel expense policies with sustainable transport. And again, we do that. And just for everyone's benefit, that the hierarchy is the worst form of travel is air. And the best really is avoiding travel and using digital, such as Teams, which again is what we do already. We already, for item 7, we are beginning to explore with Transport for Wales opportunities for staff discounts. And item 9, we already offer the Cycle to Work scheme through our benefits package to our staff. So the ask today is to support the Health Board signing the Healthy Travel Charter and to develop a comms plan. And I would suggest an update in around 6 months' time in terms of the actions. But I'm happy to take any questions. And as I've mentioned, I may well field them to Matt, who's in attendance. Thank you.
Thank you, and thank you for the work on that. I'm glad we're in a situation where we can hopefully sign. Any questions?
Absolutely supportive. I suppose at the start, but maybe just, it's a really small point, but budgetary and financial implications. And I understand when we say there's no cost associated with signing the charter, and that's right. But if we're committed to the charter and committed to implementing it, then there will be costs associated with that. So, not saying it's disingenuous. I'm saying that we need to have a mind to it, and perhaps we need to consider that. Maybe just rephrase slightly.
Okay, diolch yn iawn. Claire, wedyn Gareth.
Diolch. I had a chat with Matt in the break, so I think it is a great piece of work. I'm absolutely behind us signing up to this. The questions for me are the kind of bigger regional ones around how, as a regional organisation, in partnership with local government and others, do we get to a position where people are able to choose healthier travel options? Because for a lot of our region, Earth has referred already to travel quite a lot this morning. It is very difficult for people not to travel by a car with one person sitting in it. So I think as a whole region for North Wales, and it aligns with everything in terms of the 10-year strategy and our strategic intent, our work with the RPB, we've got to get to a place where we manage better together the needs of our region in these spaces. And we all know over the last 10 years in local government, due to financial pressures, many bus routes that were heavily subsidised have had to be reduced or curtailed, and it's now harder for people in our rural communities to use public transport. And indeed, many of our train services are, it's great if we can get discounts, but there are insufficient services to the major places at the right times of the day. So I guess I'm interested in how, as an exec team and working with partners regionally, we start to get in a place where we can deliver better public transport services, and that's perhaps one to come back to as part of our strategic intent, really.
Diolch yn iawn. Gareth?
Yeah, very quickly, I'm very supportive. I think it's quite a long way to go. Somebody who walks to Carlton Court quite a lot. I never see a cyclist on the cycle lanes, which are laid out very beautifully on the business park. I don't think I've ever seen a cyclist, interestingly. Certainly not me. But my main point was just to say, I quite like the idea of proactive, sustainable travel champions. And if it's appropriate, because it talks about elected members, we're not elected members. I'm very happy to be one.
I think you're already accomplishing that role. Paolo, Nessa?
Yeah, just to draw out some of the things that came up in the executive committee when we discussed this. Clearly, as an anchor institution, the importance of us role modelling and signing this is absolutely critical. And we want to use this as an opportunity to make sure we're reviewing what measures we've already got in place, as well as what else we might put in place to really meet the spirit of the pledges. Like that builds on Chris's point around, some of those might require investment, and as Stuart said, they've come through, be judged on their own merits. I just wanted to make your link, because travel's come up a number of times in the discussion today, but it links heavily to the clinical services plan as well. So we're, just to reaffirm to make sure that all these things, including healthy travel, not just travel links, are going to be taken into consideration in that work.
Yeah, diolch yn iawn. Mae hyn yn codi lot o faterion, a falle gall.
This brings a lot of issues, and if I could ask Claire to look at the progress in this work and the input, and it does address a number of things: public transport. There are buses in rural areas, but they're not regular enough to work with your appointment times. And as we plan our estate, it's like a road that is filled with cars. We need to consider the mix that enables people to use public services or other matters. And if they're available, that's the whole point. There's no point in us trying to promote something if that service is not available or not suitable to go with other people's demands. So if you could keep an eye on the progress and the financial implications. Are you happy for us to sign this charter, though, later today? could we also thank you for the work? You've seen the ambition not to just sign the charter, but to achieve its objectives. We'll move on to the next item, 2.7, and the report, staff engagement and culture and experience. You will know about the significant work in this area, and this notes another step on that journey. Over to George. It's a lengthy and detailed report. I wonder if you could just outline the main items so that the work can carry on.
Yeah. And I too would like to thank the team that have put the report together, but also all of our employees that have contributed to it, and particularly our culture change leaders who've had a real influence in this piece of work. So the report provides an update on the culture and leadership programme. The work aligns with the Welsh Government's ambition for a national culture and leadership framework, and our experience has positioned the Health Board as a key contributor in shaping this agenda. Indeed, we've been complimented on our work in this area and for the quality of our report, of the synthesis report by Professor Michael West. The programme is central to delivering strategic objective 3 of our of our integrated medium term plan, creating a compassionate culture, leadership and engagement. The synthesis report summarises findings from the discovery phase, drawing on multiple sources, including previous NHS staff survey, the foundations of the future engagement and staff wellbeing data. It identifies key themes, challenges and opportunities which have informed the 3-year improvement plan, aimed at embedding cultural change, improving staff experience and ultimately enhancing patient outcomes. Key themes identified include the need for a consistent application of values and behaviours, streamlined governance, improved psychological safety, enhanced leadership capability, and greater support for innovation and wellbeing. The 3-year improvement plan will be implemented with immediate priorities focusing on embedding of values and behaviours framework and leadership and development programmes. Progress will be monitored through the People and Culture Committee, via the Culture Dashboard and ongoing staff feedback. Recruitment and development of culture change leaders will continue to maintain momentum, supported by strengthened communication and engagement plans. The Culture and Leadership Programme is delivering measurable progress and providing a clear framework for cultural transformation across the Health Board. The findings from the discovery phase confirm that while there are areas of strength, challenges remain in embedding values consistently, improving leadership capability, and creating an environment where staff feel safe, supported and empowered. Next steps are contained within the 3-year improvement plan, which sets out a structured approach to address these issues and build a compassionate, inclusive and high-performing culture. Successful implementation will require sustained commitment from the board and senior leadership, alignment with organisational priorities, and ongoing engagement with staff at all levels. This work is fundamental to improving staff experience, strengthening organisational effectiveness, and ensuring the delivery of safe, high-quality care for the population of North Wales. The board is asked to note the findings of the report and endorse the suggested culture and leadership improvement plan and continuation of the culture and leadership programme.
Thank you, and thank you to everyone who's been a part of that work. We're asked today to approve the improvement plan and to note the content of the report. Are there any questions? I know that David, as the chair, has been having an oversight of this. Briefly, thank you to George for presenting the work that has been undertaken. What's important to note, I always say this is a journey. It's not something that happens overnight. So it is important that we keep an eye on the progress, and the committee will obviously do so. But we've talked about this with internal audit and how we keep an oversight of how this is then ingrained into the organisation from the top to the bottom. I don't like to use the term top to the bottom, but everyone, I think, is what I mean. And thank you for everything and the report.
Diolch. I just wanted to say that having had interactions with the culture change leaders, whether in the more formal session and going out and about and seeing people, just commitment and passion that they're bringing forward, and the fact that they're not afraid to challenge poor behaviours. I think it's really evident out there, you know, having discussions with people who feel empowered because of the programme. It's been really good. And I think if we can get, as it says in the report, the critical mass, then we've got a real opportunity across the organisation for cultural change. So I think the methodology, the way it's been grown rather than it being a big bang, it's been almost, you know, planted and then nurtured, I think is absolutely the way you've done it right as a team, and I just wanted to commend that.
That is a point well made, that this work isn't starting from a blank sheet of paper. It's in the context in which we operate, and people been in the organisation for many, many years, as referring to earlier. So it's promoting culture we all want to see, but it's also challenging the culture we don't want to see. And you can't do that as an individual. There are instances where we could refer to, not this organisation, but other organisations, where you can't do that as an individual. So it's really important that we get that critical mass you referred to, Angela, and you know, the term that they use in work and other places is you reach a tipping point where things are very clear what is acceptable, what is not acceptable. But that is a change that is going to take time. Absolutely correct to say that. Got others want to contribute. I know Clara wants to come in too. So
really appreciate the report. Thank you for all the work that's going into this. We can't underestimate how resource intensive and how long term it is to fundamentally change a culture from kind of bottom to top, or however we want to describe it. And really good to hear the work of culture change leaders, but we are a huge organisation and we've got to get to that critical mass and tipping point. So I guess my question is just thank everyone for the work. The plan at the back end of the paper is really good to see, really clear. Are we confident we've got the resources to deliver it? Because I'm sitting here today seeing a strong connection between this paper and the value and sustainability paper, because get the culture right and have some great systems for people around change and improvement, and the organisation will fly. But that does require a really strong focus in terms of making sure that we're adequately resourced to deliver on all of those fronts. So it's a specific question around the culture change programme. Have we got the resources we need in the right places, or is there more that we need to do in this space over the next year or two to make sure this programme can really deliver for us?
Clara, what's your next?
Thank you. And I mean, it's referenced within here, but I just want to remind us all as well that the importance of this culture change associated with safety and clinical outcomes for patients, and that we know that in departments that work cohesively together, the outcomes are much better than where there is strife, for want of a better word, within the department. So I just want to be really clear that it is important that we are all working together associated with these values, but it is equally as important for the outcomes of our patients as well.
And when people are working under extreme pressure as well.
Yes.
There's effect us all, isn't it? And when you're under pressure, then respond in a different way. So Pam, I'm going to bring this to an end now. So Pam on governance, and then Carol to sum up, and back to George in case you've got any points to add.
So it's just because it's a suggested improvement plan. One of my thoughts, George, would be there's quite a lot in year one in terms of what's going to happen, then year two, year three. So I was just thinking that it would be really helpful to have a bit more work on this, which would take through people and culture committee, just in terms of the final sign off. And then that would be the vehicle in which it will be monitored, progress will be monitored in terms of assurance then up to board, and notwithstanding all the other comments. I think some of these sort of actions I think of a bit sharper, just in terms of what will we do. So it's just that I think as it's a suggested improvement plan, sharpen this up, take it to people and culture committee, and then it'll be that with the vehicle in which the board can have that assurance around monitoring. Yeah.
Diolch yn iawn. And Carol, some comments, John, if you want to make any final remarks.
Thanks very much. I agree with all the comments about the culture takes a long time to change. However, I think we can change cultures with every single interaction that we have by role modelling. And I know as a board we made a commitment to this back in 2023 when we worked with Michael West, and we went on this journey. So I think it's really helpful to have this back here today, so we're able to reaffirm our commitment to the work. And very many of us interacted with the culture change leaders as part of that survey. I think this is potentially, the culture change leaders a standout for us as an organisation, and I think more and more people are getting interested in that. It comes with development, which is a fantastic give and get. And I support the tipping point. Just on resources, I think there's something about the culture change, Jules made a point on this culture change function that we have, the team, but actually we've got to hardwire the culture change into every leader and manager's objectives. You know, we now started to measure much more and have very visible measurement of the culture and staff engagement in each of the departments and teams. And then I just wanted to emphasise Cara's point about team working. Team working is one of the single most effective ways of improving care. We know that it does save lives, and we've also got this investment in team working, and that should be from board right the way through to the community ward. And we've been investing ourselves in our own team working, which I think is really important in setting both a culture and a mission around this group. So thanks.
George.
So just to finish, I suppose, just to remind colleagues that this is part of the Foundations of the Future programme, one of the 5 work streams about how we change our operating model. So it's a really fundamental piece of that programme as well. Yeah.
Diolch yn iawn. A diolch I bawb am y gwaith ac yn
Thank you to everyone recognising all of the work that has been undertaken thus far. Everyone happy with the suggestion that the relevant committee, culture and committee, provide the overview and the progress? Everyone happy to do so. Thank you. On to item 3.1, emergency and urgent care update and workaround transfer from ambulance. We've mentioned already in this meeting Tamina, and then right at the end of the item we will have a video about the service that I've already referred to, the MEC. First of all, Tamina and the colleagues. Tamina, over to you to kick off.
I think this will be a bit of a joint effort, because quite rightly there's a number of people who were involved in supporting our improvements around the urgent and emergency care pathway in terms of patient experience and outcomes, and also our staff experience as well. I make this point on a regular basis. We have some phenomenal staff doing some incredible work in quite challenging circumstances, but the feedback we get is when a patient is in front of a clinician, they get extremely good care and treatment. So I did want to kind of really emphasise that in and around some of the concerns that we discussed last September. And then echoing Carol's point earlier, the issues are, and the congestion is experienced in ED, but it's not an ED problem, it's a whole system problem, hence why there's a number of people who are involved in looking and developing some of the solutions. Since we met in September, we've done a significant amount of work, quite rightly. There's been a combination of executive walkarounds, just really trying to get a feel, minute by minute, what it feels like to experience care and to give them care in our EDs, but also more broadly in terms of what's happening in our wards and at the front door as well. And an example of how we then acted on that is the executive director of nursing, the director of medical director, sorry, and myself as the chief operating officer have spent time with our senior leadership teams, really working with them to be very specific about the actions that can and should be taken extremely quickly to try and resolve the situation, as we said last week in the public accountability meeting, so that we deliver some changes for our patients and for our staff by Christmas. Each site has now got a very focused action plan, which is reviewed and scrutinised by the chief executive and the clinical executive and myself on a weekly basis, supported by the data and performance information that we need to be using to really help us evidence where the challenges are we need to improve, and then to measure whether that improvement has taken place. So thanks to Russell for supporting that as well. I think it's worth saying that we are really building on the work we've done around the winter planning to develop some really strong partnerships with our local authority colleagues, because when we look at one of the main areas of focus, which is around discharge, we really need to be working with our partners to make sure we're reducing the number of delays and we are expediting discharge where possible, where those patients need support from other partners. We've also in the last couple of weeks had an external review of the flow within our emergency departments, but also the way in which we're managing discharge and reducing delays in our wards from the performance and improvement team supported by NHS Wales. Some really helpful insights there to really focus and hone where we want to be spending our time specifically over the next 6 weeks. And shortly I'll ask Claire if you can just update with Angela on the quality summit that was held a couple of weeks ago with our clinicians and clinical leads to really focus on our main concerns around quality and safety, and specifically what we want to do around that. In the next 6 weeks, we'll be focusing on what's happening at the front door, because we need to make sure that when people attend ED, they are in the emergency department when they need the support and care they need there. Otherwise, how can we help them to use some of our other services, so urgent treatment centres, for example, or same-day emergency care, some of which are delivered on those sites, but also open up other opportunities around, for example, minor injuries units to make sure they're available when people need them. We're then looking specifically at the management within the emergency department. So what can we do to decongest that space so our clinicians have space to assess, care for and treat our patients, and then make the right decision about whether they need onward care within the hospital, or whether they can be discharged back into the community. And then where I think, and I think all of us think the biggest opportunity is around what in terms of our discharge. So for us, good discharge looks like when somebody goes to a ward, they have a discharge plan from the moment they arrive. So everyone knows exactly what needs to happen with and for them to enable them to go home or onto their next care treatment area in a really timely fashion. The best place to be is somebody's own bed, and we really want to expedite and facilitate that. We want to make sure that where people are being discharged on the day, the majority of those happen earlier in the day. It's better for that individual to get home in the day rather than later in the evening, but it also allows us to create space in our ED departments by pulling out people who are waiting there for a bed onto the wards where they're going to be receiving their onward care. And then the other thing for us is to improve by around 30% the number of discharges we achieve at the weekend, because the number of discharges at the moment are much lower than we would achieve between a Monday and a Friday. There's some very specific activities there, and some of that is working with our local authority colleagues. We now have the opportunity to look on our live dashboard at what's happening with our patients at any given day of the week. Previously, we only had a snapshot taken once a month, so we can then work with our local authority colleagues to say, we have a specific patient, they're waiting for this pathway of care. How do we work and support them to make sure they go home in a timely manner? And then finally, making sure our internal processes are really tight, so that anybody who can go home without any onward support goes home at the time that we deem it appropriate for them to do that. ultimately we only want somebody in our acute hospitals when they need all of the support and infrastructure that you have there, and the point at which they don't, we need to make sure if they need onward care and treatment, it's in an appropriate setting, but maybe doesn't need all of the kind of the equipment, the skills, the expertise that you would cite in an acute setting. So a range of things we're doing specifically over the next 6 weeks, scrutinised by the clinical execs and other relevant executives on a weekly basis, supported by a clinically led task force that's really driving and taking forward these changes. But I think the other thing for us is real visibility on our sites so that our staff recognise that we understand what the challenges are and we're really there working alongside them to make those improvements.
Tamina, that's very comprehensive, and we'll comment on some of that, I'm sure. Just checking with Claire if you want to come in now, then Dr. Panjo wants to come in next.
Yeah, so the concerns for myself and the rest of the clinical execs are obviously safe and quality care for patients within the emergency pathways, and that the staff there are being able to provide the care as they need to do so. And as Tamina says, they are trying their very, very best in tricky circumstances at this stage. So quality and safe care is reflected in a lot of the key performance indicators that are within this paper around rapid handover from ambulances, time in the department, time to triage, etc. But there is more to quality of care, these performance metrics, and so we have therefore had a rapid quality summit to work alongside the operational teams to look at this in more detail. And again, as everyone is saying, emphasising in this time the professional responsibility of everyone within the hospital site to make sure that the ED and pre-ED pathways are safe. So we've looked first of all at how we check safety within the department, and you can see from the paper the approach that we took within the Quality Summit, and I'll just pull out some of the instances, some of the issues that we discussed. We discussed first of all reporting of incidents, and these can provide snapshots of safety of care within the department, and we have a very well-structured process for picking these up, linking them with complaints, concerns from the medical examiner, etc., and then progressing to investigation and executive oversight with weekly executive oversight panels for that, and then ensuring that learning comes out of those. And recent learning has been associated with how oxygen is used and how we, for instance, follow up blood test results for patients within emergency departments, but many others as well. What we've suggested associated with the Quality Summit is that we move to some must report events, which then gives us a better idea of some of the incidents occurring, and we're just working through exactly which those will be. And again, we'll review those in the same way that we do with incidents, which is a panel attended and chaired by the clinical execs every Tuesday morning. We also are looking at some of the time-sensitive pathways. So we've discussed already about stroke this morning, but stroke, myocardial infarction, so heart attacks, fractured neck and femur, for instance, are all pathways that need attendance to patients within a specific time frame in order to get the best outcomes. And so part of the Quality Summit was looking at how we are doing in those particular areas. There is some variation in process and indeed speed within some of our departments, but equally one of the things we looked at particularly, and this is not just for us but is in many emergency departments, is that the difference in time, for instance, around time to treatment for heart attacks, whether you arrive on an ambulance or whether you walk in. And this is something that is a problem for everybody within the NHS at the moment, but beginning to focus on issues like this specifically in the emergency pathways, translate some of those key performance indicators into things that feel really important for patients and for clinicians to understand. Myself and the other clinical execs will be due to issue some quality standards along with Tamina around operational standards at the beginning of next week, but essentially say we need to be mindful of current issued internal professional standards about this this concept that everybody owns the safe quality care in the emergency department and must work with operational colleagues to work closely with the defined plans that we have outlined. And as I've said, we will continue to measure through our executive oversight panel. I'm just going to hand across to Angela for some specifics around corridor care and boarding.
Yeah, Angela.
Yeah. So we've talked at previous boards around corridor care and around the support that we give to those patients on the corridor who, overflow in the ED department means they're not able to move up to the wards. So we have identified extra nursing staff to allow us to care for those patients on the ward. We are undertaking what we call intentional rounding, which is a regular check of those patients to make sure they've got what they need around toileting, food and drink, observations being undertaken, medication rounds and things like that. So we are identifying those patients having the same cover as if they were on a ward area to allow us to make sure that they're given that opportunity for care and we can make sure that they're safe. Our nurse in charge of each of our EDs is undertaking patient safety rounds, working with the clinician in charge to make sure that there's escalation if there's any concerns to any of those patients. And we're undertaking deep dive audits to identify if there's any lapses that we can actually address immediately. My senior nursing matrons, heads of nursing and directors of nursing are overseeing these patients and making sure that we've got escalations. The work we've been doing to make sure that we've got the appropriate patient flow so that we don't have patients on our corridors in ED is around work. We're going to be calling it Our Next Patient Please. And we do have aspects of it on each of our sites currently where we'll identify if there are patients who are ready for discharge on that ward area, then we get patients ready in ED and move them into the ward. Whereas a patient ready for discharge can release those beds to allow them to be able to be discharged from the ward. It's not as consistent as we would like. And as Tamina says, we're going to be doing the work on discharge and increasing the numbers of discharge, which will mean that we can use our next patient please a lot more effectively. So currently the information that we've been taken from each of the 3 sites is being coordinated, and I'm expected a final draft to come to me tomorrow of the policy, but which also will include an opportunity for us to identify de-escalation of the ED area in extremis. So if we're at a level 4 and a hospital full, where we could potentially move our patients to a more safe place than the ED department that can get that nursing care. So that will be agreed and then that will be socialised and hopefully will be ready for us to implement the same time as the discharge weeks.
Diolch yn iawn. Nifer y gyfraniadau pwysig yna. Dwi'n gwybod bydd yna gwestiynau sylwadau.
Thank you very much. Very important issues there. I know there will be questions.
Where we are now following our September meeting, I think we've heard today and previously a lot of actions, a lot of work, a lot of intent, which is very encouraging and important. It will be significant for patients and our staff when all of this makes a difference. So I think we're in that in-between period, if I can call it that. But we've got to ensure that all the actions that will be described, all the actions in the paper, have an impact, a positive impact in terms of waiting times, in terms of people's experience, and so on. We absolutely recognise the wider context and the whole system's work. I emphasise that myself repeatedly. We've got the short-term problems, which are hugely challenging for our staff. So we've got to do everything possible to turn these actions now into impact and making a difference in the way that we want to. But can I also underline at a particularly challenging time because of the extra winter pressures, as we heard from Jane earlier, around flu and so on. So we know we've got to drive even harder to against that challenge, as well as the normal circumstances, as it were. But that's the expectation of our staff and the public, I think, is that, right, we've set out a clear direction, we've got to ensure improvement. We've got to ensure that things get better. Otherwise, those actions would be worthless, quite frankly. Right. Cwestiynau a sylwadau. Rhian gynta, wedyn Arthur.
Questions and comments, Rhian, then Arthur.
Talk about the front door. I think I need to understand a bit better, maybe not here, but the triage process. You've got one triage happening, in theory, 15 to 20 minutes. But then you've got the clinician, the decision triage happening in an hour. So where does the authority lie to say, sorry, you don't need to come in here, you need to go in somewhere else? And what is in place to facilitate that transfer if it's appropriate? So I wasn't quite clear on how it all worked.
Yeah, that's a really important point where those clinical decisions can happen earlier in the process.
But also where the support is.
Yeah.
If somebody decides, well, sorry, you don't really need to be here.
Yes.
But I will pick up a phone to the
Yes.
local authority and
Right.
get a social worker in for you, sort of thing.
Yeah, not just saying couldn't be
Go
here,
away.
but where you should be. Yeah, and the support, as you say, really important point. Arthur, ti nesa, wedyn Billy, wedyn Dyfed.
Yeah, it's really interesting to hear about the plans, and I can see it alive, especially, our next patient, please, which is, again, it's a change in culture that's happening here, isn't it? And I'm just wondering what the messaging has been around that and how engaged, obviously it affects staff in ED, but it really does affect staff outside of ED. So just wondering about the messaging and how it's been received. I'm not sure.
Point. Yeah, Billy.
Yeah, I just a question on the patient flow approach. I'm just kind of worried that we will be shifting corridor care from EDs to the wards. I know our next patient, please, is used extensively in South Wales. Just wondered if we are learning from South Wales and putting in so that corridor care or patients being treated in inappropriate areas won't be happening in our.
Yeah, really good point that we don't juggle a problem and move it from one place to another, but rather try and address it. So really important points with an opportunity to respond. Dyfed, ti nesa?
Dwi'n mynd I rhywun o'r fideo.
I won't take away from the video that we're watching, but I know that the partnership across the local authority to move things forward is working effectively. I know from the viewpoint of Anglesey how good it's working, but it goes across other authorities that see the benefit. And the point I want to make here, this shows what's in place, when the levers move, but that we see the impact, because these tools are there, but we must make it work. Recognising also the partnership with some of the local authorities, and I was in a scrutiny committee for Anglesey yesterday about this point. And we heard about the excellent work that is happening in the Middleton to support people. Harold, do you want to come in?
Yeah, thanks very much. So there's a couple of points I'd make. We must make progress, significant noticeable progress by Christmas. That's not because there's a celebratory event or any of that. It's because that is the turning point at which we've seen a regular amount of further increase of pressure And if we've got pressure now, we add that on, and that will be, well, it feels at times extremely difficult to maintain the right safe environment for people, layering that on. So there is a very clear fine way.
Yeah.
I think the paper does set out those 7 key actions. There will be other things that are going on, but those 7 key. But the one single thing that if we can focus relentlessly on it, will make the biggest difference is discharging people from hospital who do not need to be there. And that's because they suffer harm by being there too long. And people trying to get in are suffering harm because they can't get in. So there's a benefit for everyone in this. And I think that's why, you know, in the order here, number 1 is the discharge fortnight. That will provide the impetus. And David and I have written to our colleagues in local government because together we can have a bigger impact on that. And there are people in our communities, and we just put one figure in there, about 8,000 bed days. We can imagine if we could reduce that by 20% even. I know, you know, with marginal gain, but it will make a really significant difference. The other things are very important, and we've got clear leadership around those things as well, but that in and of itself will make a big difference. What we're trying to do is to risk balance across the whole pathway here, not move risk from ED to the wards or, you know, the community. We're trying to risk balance. And there's very many opportunities for different options of care. Be very happy, you know, Lee and other colleagues to go through, because there's screening, then there's triage, and then there's clinical assessment. There are different opportunities at different stages to offer people a different and better alternative to an ED visit. When I was chatting to some of our TOS team last week, they feel reasonably optimistic that we do have a range of those alternatives, but we fail to successfully connect people all of the time to them. So they do think that there's opportunity there. So
great. And just to underline the matter of discharge, to put it in context, Ysbyty Gwynedd, which is not too far away from here, if you imagine the wards in Ysbyty Gwynedd with patients, that is the size, that's the number of people we have on average on a weekly basis that are waiting to be discharged. They are medically fit to discharge. So on average, we have a whole hospital full of people who are medically fit to discharge and are therefore taking up beds and the time and energy of all of staff, where other people need, just to put that in context. Right, some remarks to close, and the emphasis on a message of improvement and progress and some hope for our staff and patients. So, Tamina, I'll turn to you first, if that's okay.
I'm so pleased to use the word hope, because I was going to start by saying I feel extraordinarily hopeful about the opportunities we've got to improve the situation at the moment. We've had a conversation with Bertha last week about why I think that's the case. There's a lot of opportunities at different parts of the pathway, lots of areas to improve, but principally we've got some clinical and operational staff who are really keen and really want to make a difference and make a change. They are the absolute experts in the things that would make a difference. And I see our role in making it possible for them to take some decisions, do some things in a different way, reflect on that, and then kind of embed that in. So for me, that's incredibly hopeful. Something like a reset fortnight, it does really focus us both internally and within our partners, and some really clear metrics that we can work hard to, that will enable us to deliver during that fortnight. But it's not just for Christmas. We need to make sure that in January, February, March, we build and sustain it, so that just becomes the way that we do things. So for me, huge opportunities. It's been really, really helpful to get the wider executive really engaged, involved in this in a coordinated way, building on the enthusiasm and I think the expertise of our staff and our partners as well. So I'll probably just close with that, if that's okay with it.
Beyond Angela.
Diolch. Just to come back to Eartha initially. So the messaging received, we could have implemented the changes a few weeks ago. with the drafting has been done for a few weeks ago, and pressures suggested we needed to do something different. So I have been speaking in my forums with heads of nursing, with matrons and ward managers, but my directors of nursing have been having those conversations as well around the messaging, around what we need to do differently and where the risk is within the organisation. And that's the reason we need to socialise the protocol policy first before then we have the implementation, to enable people to understand where we're going. And then from Billy's perspective, we have looked at South Wales. I've reviewed the South Wales processes and the learning that they've had from where they are, including the patient leaflets about somebody, if they are placed in an area that they shouldn't necessarily be unless it was an emergency, then how that works and the family to be informed. I think if we can get the patient flow around our next patient during office hours, if you like, Monday to Friday, 9 to 5, we've got a discharge lounges on each of our sites where the patients on the wards will be moved to the discharge lounge to allow us to have the bed spaces to move those patients in, but in a scheduled way to understand that the ward will know when they're getting their next patient and they'll be ready for that patient. From a perspective of out of hours, in extremis, there will be triggers of when we utilise different areas. They've all been risk assessed by the directors of nursing, and I'm personally going around visiting those areas in the next few weeks, identifying where those areas are. And we've undertaken a risk assessment with the medical staff and with the nursing staff to understand what the risk is of having those corridor patients when it gets to an extreme, and having extra patient, and we're talking about one extra patient on a ward of 30 beds, 25 beds, 24 beds, in a designated area that's been risk assessed, compared to a corridor with multiple patients in an ED that is now overflowing. So there'll be triggers and there'll be a monitoring. It'll also get reviewed in a debrief after it's been triggered, and we'll look at it at the integrated panel on a Tuesday morning if it is triggered, to make sure that we've got the patient safety where it needs to be.
Yeah, definitely. Can I just ask Pam, from the perspective of reporting, I think I was correct in saying that reports of progress should go to QSC, the Quality Improvement Committee.
Yes, so I think there's a bit of dual reporting here, I would suggest. So I think in terms of the performance elements, I would suggest at least report through performance and finance. I do think because of this, safety elements, but I do think that the board might want to have oversight of this every meeting, until you're satisfied in terms of any de-escalation and anything. So that would be my advice.
Yes.
Performance every meeting, as well as QSC, and the safety issues, and then the overall to report to the board.
Yeah, and I've already signalled that this item will be a standing item for the next months, but the committees can do that detailed scrutiny, looking at members of committees, and then please share your work with the board then in terms of assurance, in terms of what we discovered. So that's a good opportunity to give the support and the challenge, I think, in this space. Right, pawb yn hapus i dderbyn yr adroddiad yna. Gawn ni ddiolch.
Everyone happy to accept the content of that report? Can you thank everyone for the work? We want to support that work over the next few weeks to ensure that there is progress. Everyone happy? So the video I've mentioned in my report the message I got from Rhys, I think. Who else is there back over there? Please tell us who you are.
Thanks. Nessa.
Good morning, Corridor, and thank you for your time.
Yeah, diolch yn iawn. Diolch yn iawn, a nes I gyfarfod chi gyd, os dwi'n cofio'n iawn.
I've met you all a few weeks back. following the request by Rhys. We saw this item in September and said, look what we can do to help the situation. I won't talk anymore, but we'll watch a video now to show the work. Thank you so much for preparing this video. That will hopefully provide an idea of the work.
Thank you for your time today. My name is Rhys Jones. I've worked for the Trust for the last 30 years as an advanced nurse practitioner in Ysbyty Gwynedd, and I recently joined a community team known as MEC-Morn 18 months ago. We're in a small team called MEC, which is essentially a hospital at home service, and we work closely with all the GPs on Anglesey, covering the whole island, looking after patients who essentially have complex issues, who don't want to go into hospital and who wish to be treated at home safely. Since starting with MEC-Morn, we started a very successful initiative working in collaboration with the sleep and ventilation clinic in the hospital. Together, recently, we've targeted 25 patients who are frequent flyers into the hospital last year. From these 25 patients, last year they had a total bed stay of 892 days. Since they joined the trial, and since MEC have been to review them, we managed to keep every single patient at home since January. Now this is equivalent to having Ysbyty Gwynedd and Ysbyty Glenclwyd, all the acute beds empty for one whole single day. We not only look after the COPDs, we also look after any acutely ill patient that basically want to be nursed at home. So this could be AKI, acute kidney injuries, COPDs, chest infections, UTIs, confusions, patients with social issues, patients dying, coming to the end of life. We manage to look after them and keep them home. We work closely with other services, district nurses, social services, occupational therapists, physios. We managed to do this without any additional funding, streamlining patients, and we've also taken on additional services for the heart failure. There's no heart failure cover, unfortunately, at the moment for the foreseeable future on Ynys-Môn. So we've also taken these patients on. Patients don't want to go to hospital these days. They're fully aware of the risks of catching infections. They're fully aware of the delays in ambulances, the delays outside ED departments, the delays inside ED departments, waiting to be treated, while they can easily be treated safely at home. I think we've already proven the success already with the small initiative we're doing. If MEC-Morn could be a model that can be spread across Betsy and the whole of Wales, I think we will have a big impact and definitely ease pressures off the main hospitals. Thank you very much for your time. Diolch yn fawr iawn.
Diolch yn iawn am hynny. Reit,
Thank you very much. Any comments or questions?
So we're all struck with the statistics that were presented.
Yes, are we doing it elsewhere?
Right, we'll come to that. That is the fundamental question, and basically,
My question is just round asking you all. It's just incredible that the number of things send up.
It may show my ignorance, but why aren't district nurses doing this?
Sorry,
why aren't district nurses doing this? Anyway.
Yeah. Okay. Thank you very much. Anyone else? Claire?
Perhaps not a question at board level really, but I'm interested to understand how the process works, so how someone accesses the service rather than getting themselves to ED.
Yeah.
Who does it? Is it via the GP?
Yeah, absolutely. So, Carol, I'm going to ask you to feel, but I know, please, me, if you wish to turn to him, I'm happy for you to do that because he's and the team here and they are experts in the field, and please, beyond them to share anything further, I'm sure they would be happy to do so.
I'm very tempted to ask, can I come out and do a clinical day with you? Because, you know, I think we are
trying to change the mindset of ourselves as clinicians and clinical teams, that we can provide more care, more complex care actually in people's own homes than ever before. But that requires a level of confidence, I think. I took only from that little video a real sense of confidence in the range of things that can be provided. We do have in the region of 36 different types of models across North Wales, which will be of no surprise to some of us, I'm sure. And so, but they're all a little bit different. So I think there is absolute merit in drawing together the features and characteristics of the best that have the greatest impact, the best care experience for individuals. So I did wonder whether there's been much sharing, Reece, across and learning from different parts across the region. And that's particularly important as we move forward now to get a more consistent sort of approach for people. I will leave Angela to do the why aren't the district nurses doing this. You may have a view on it actually, Reece, but I wondered if we did want to bring Reece in to just share some thoughts.
Dros at ti, Reece.
District nurses that I've had outside of highly qualified practitioners, we prescribe, we shifts, treatment based levels. So district nurses can do that. But I see those files. My ex-department experience is military and acute medicine for the last 10 years. We're doing that into communities. We're doing the hospital into communities, and that's important to avoid getting myself, keep on our home. We're looking at them into ED, the job, discharge, we keep them home and absolutely not great.
So, a great insight, if I may say so, and it occurred because this team could see an opportunity. From the challenge, we were discussing as a board, look how they responded. Isn't that fantastic to see? Isn't it something we should welcome and encourage? When people see a problem, it's not something I say frequently. We're often seen leaders of this organisation, but actually we've got 20,000 leaders, and you've shown leadership by bringing this to our attention and the possibilities. So, going back to that fundamental question, what are we going to do about it?
Yeah.
And when and how?
So I feel like doing this. In the paper that we just discussed, we talk about the single point of access and alternatives to hospital. I don't tend to like that phrase, alternative to hospital, because what you're actually doing is providing enhanced care close to home, and we're recentering where care should happen. Gareth, you said earlier, 90% of people have care through their family and community. And so investing and getting a more consistent offer for people, I think, is really key. Tamina may wish to comment a bit more on the single point of access and how we then plug in to all of these services. There may be more potential, Reece, for more patients or to diversify. We haven't taken on virtual wards, but it sounds as though that's a pseudo virtual ward, to be quite frank, by any other name. And then I think that the opportunity is to apply consistently this type of approach across North Wales. But Tamina, a brief view on that as well?
Yes, absolutely. So single point of access operates at its best where it's got really up-to-date information that anyone can access to say, you're presenting, a patient's got this particular issue or problem, this is the best place for them to receive some care or treatment. And that could be, the point about district nurse, it could be contacting the local district nurse team to say, could they go out and do a quick assessment? Could they do a, I don't know, just check their medication or whatever, and make sure they got a regular kind of appointment with their GP, whatever it might be. So for me, that's how it works best. It's usually for healthcare professionals to contact. When you've got a really well-established and mature single point of access, you can also allow sort of direct contact from a patient or their family as well. So something we would certainly want to work towards. But I think I'd echo Carol's point about
I mean, I've done a lot of work in the community, and for me, the community is, and primary care is kind of the heart of the care that we provide to people. And you only need to go to the big building on the top of the hill when you only need what support you get there. So you're absolutely right. It's not about avoiding admission or attendance at hospital. It's about providing appropriate support as close to that person's home as possible. Many of you heard I've got a 91-year-old mother. I don't want her to be trundling in to any kind of hospital environment where she could get some care or support at home or in her GP practice. So really, single point of access is a way of pulling all that together for people who might not know. Across a region as big as North Wales, the range of different services that we have. So, and they may look slightly different in different places because of the local population, because of the need, because of the geography. But the core principle is, what can we do that improves access for people close to home and keeps them as close to home as possible where they can receive their care and treatment. In England, it's sometimes described as a virtual ward. It can be an urgent care response within 2 to 4 hours. It could be, if you know that someone's going to come and see somebody within 24 to 36 hours, they can comfortably stay at home with some kind of safety net around them. So all of those things, I think, are wrapped up in that.
Diolch yn iawn. So, can I ask for an opportunity to reflect on this and consider where the opportunity is? Maybe we need to do a bit of a review of what's happening currently in the health board in this space, and then consider what we can do to develop. We already know that GPs, for example, in neighbouring towns and villages are saying, well, please can we have this, and so on. So there is a need there. I think we need to assess what the provision is across the region currently. How can we develop it to make sure it's most effective? What does it mean in terms of resource? What does it mean in terms of aligning with some of our strategic discussions we've had today?
And I'm just wondering whether we're going to review this area again in January, whether we can do that rapid assessment. Let's see what it looks like fully across the region and identify that opportunity. So I'm sure we can do that and ask colleagues for help as well.
Yeah, that'd be great.
Yeah. Yeah. Lots of potential.
Diolch yn iawn eto am y gwaith. Wel, yn wych iawn gweld y fideo ac golygu y bryder ar awydd I gynnig.
Thank you for being so keen to provide opportunities.
Yn rôl ni ydy ceisio neud rhywbeth yn ei gylch o, dwi'n meddwl. Felly, gadewch ni weld sut mae'r gwaith yn datblygu.
Let's see how things are developing and an opportunity to reconsider in the future. Thank you very much. Everyone happy? Thank you. We're continuing to run later and later, but I will take item 3.2 and 3.3 before we break. Item 3.2. I'll move to Eartha to report instead of Caroline.
Wedyn Angela yn yr adroddiad ansawdd I ddilyn. Diolch yn iawn.
Caroline is not here, that's why I'm presenting this report.
I would like to mention the recent child protection review in Gwynedd, which I'm sure everybody is aware of. So the Health Board has, the QSE committee has received information on that, and we will be looking to receive a further report on how it will impact or what recommendations actually affect the work that we do. So we will get feedback on that as well. Caroline was very strong at the last QSE committee on the fact that she took assurance that we did have traction in challenge services now. Not that all the problems had gone, but that we could see real feet getting embedded on some journey and hopefully moving the challenge services away eventually to her are almost out of escalation. So she expressed assurance that traction was evident in those areas. I think we should be proud to hear that clinical coding is being considered for de-escalation. There's been a 95% compliance. We did receive further update reports on the Royal College of Psychiatrists, which again was very hopeful in terms of the outcomes that are being ticked off as these are being done, And my understanding is that there will be a report coming to full board in January, I think. So we look forward to receiving that. I think the last thing I will mention is significant improvements in the number of overdue learning from event reports. As part of that discussion at the time, there was a discussion on embedded learning, which I know also comes up in other committees. So unless anyone's got any questions, I'll leave it there and respond to the request to be short and sharp.
Diolch yn iawn, diolch am mi mewn I wneud o'r adroddiad yna. Unrhyw gwestiwn gyda rhywun?
Thank you for that report. Any questions?
Na, os nad oes cyfeirio.
If not, can we thank Effa for the report?
Ymlaen felly I adroddiad nesaf.
On to the next report, which includes the annual Ombudsman's letter. Thank you.
This meeting's report identifies that national reported incidents were still in a very positive position and the best in Wales from the turnaround perspective. From the reporting period in this report, we've had one never event, which was a retained swab. We've undertaken the review of that as an exec team, and the investigation report is complete within timescales. Complaints, we're still in a very positive position, again, best in Wales for our turnaround, and we're consistently achieving that, which is really good for us. We're looking at a very good closure time. We had a presentation yesterday at execs on the new processes that were agreed in the Senate on the 16th of October, and we're working towards supporting the change in delivery across the health board to enable us to put that into place. Patient experience, we're doing well with a number of responses, and how we are communicating in preferred language has improved and is very positive. We've been given feedback from the national team around our move in patient experience, and they're very happy with the way we've put things into place with Civica across the organisation. And we're currently just looking at the neonatal capture via Civica and working through that, which will be live within the next few weeks. From an infection prevention perspective, the 29 outbreaks in August and September did result in a number of beds lost, but we are working on our disinfection isolation capacity and staff training to try and reduce the impact of those infections. But we are seeing early days positive progress in reducing our Clostridium difficile and E. coli infections. We're still waiting for the finalised standards to come out, but we've made sure that we're reflecting what we feel is going to be in the draft stages, how we can meet with that, and working closely with Stuart around making sure that estates and facilities can support us around the cleans and the disinfection. We had some exciting progress around safeguarding with the Crying Babies campaign, non-accidental injuries for crying babies. We're the first in Wales to implement the ICON programme, and it was really pleasing that we had a really good uptake, and we're hoping now we can have a success across the organisation and reduce any opportunity for those non-accidental injuries, and making sure we can support parents in the future to be able to manage if they've got a crying baby in those circumstances, which are obviously very difficult post-birth and when people are on their own at home. From an organisation learning perspective, quality management system has been mentioned in a couple of reports so far today. We are entering our full implementation phase and how we can roll that out across the organisation. The quality management system and the quality dashboard developed across BCU has been commended across Wales. We've been asked to present to a number of health boards, and NHSP and I are looking to how they can support us to make that more readily available. From a clinical governance perspective, you'll note that we've seen improvements in mortality oversight, audit compliance, NICE guidance compliance. And from a healthcare law perspective, we've already covered the learning from events, but we've had no prevention of future death notices within the reporting period, which, as colleagues will know, that the last 2 years, we've seen a dramatic improvement in those coming through.
And then finally, the Ombudsman letter, which is attached as appendices, QSE reviewed and identified approval of the submission to that. And we just need the board to support us putting the letter, our response letter in. Just for clarity, the initial papers submitted identified a 55% compliance. We've had a reissue of the letter which has been circulated to board members, and it identifies we're actually at 65% compliance, which I think on the table is actually the second best. Just a little clarity, because I know I've had some queries around this. Some of our issues is the fact that we have recommendations with England, and we sometimes don't get the responsiveness in time around that. Alva, who do very well, are actually captured within Wales and within of their area, so they don't necessarily have to change responses as we do. We also have a situation, and it has been fed back nationally, where we do get the timescales given to us by the Ombudsman, and although we identify we may need more time, we're actually measured against the original timescales, not any that have been changed and altered depending on our feedback. So that has been raised nationally. But those just were comments that I got outside the meeting. Well, I just wanted to clarify, and I think that's. I'll just take any questions.
Diolch yn iawn. Unrhyw sylwadau? Unrhyw gwestiwn?
Thank you. Any questions or comments?
54% of the complaints are about clinical treatment in hospital, aren't they? And I know the chair, in his response to the Ombudsman, has picked up that it would be useful to have a better handle on the seriousness of those different, in what area they are. So I just wanted to support that and whether that would be forthcoming.
Yeah, that is the suggestion clearly. Yeah, and instead of a catch-all category, as it were.
So I think the report demonstrates we've got so much better at process on all of these aspects around customer concerns or dissatisfaction, and that's really, really commendable. But I still would really like to see now the kind of so what change as a result. So when we look at the complaint themes, so what have we learned? Are there patterns? Are there proportionately more complaints in one location than another, or are they spread? And what are the things we're doing to reduce the likelihood of those complaints coming in the future, or to address areas that obviously are areas of dissatisfaction for our citizens? So it will be good to see that developed in the paper as we move forward, because I think as a board we've got a high level of confidence now that we're on top of all of this in terms of responding and processing. So be good to start to see some of that outputs and outcomes. Thank you.
Diolch yn iawn. Unrhyw un arall? Os nad oes, pawb yn hapus?
Anyone else? If not, everyone happy to accept the content and approve the letter to the Ombudsman. And we'll continue with the work as Claire suggests. Great. It's now almost 1:30. We'll take a break for lunch. Are you happy with 20 minutes?
Okay. Yeah, 20 minutes. Yeah. Right. Now ni ail ymgynnull.
Okay, we'll reconvene at 10 to 2.
Croeso nôl I sesiwn pnawn cyfarfod Bwrdd
Welcome
Iechyd.
back to the afternoon session. We're moving on to 3.5, the Chair Assurance for the Performance and Information Committee. We do have a written report already. Gareth, do you want to add anything?
I think, Cadeirydd, I can just pass on to the substance. I mean, obviously, I'm happy to take any questions, but I think the report speaks for itself.
Diolch yn iawn. Pawb yn hapus I nodi'r adroddiad yna.
Everyone happy to note the content?
Diolch. Ymlaen I 3.6
3.6 then, integrated board meeting. Russell.
Family members, I will hand over to some colleagues just to have comments. I know we've had the quality update already and we talked about emergency care. So if I focus on the primary care position, so you'll see from the reporting that we have over 52 weeks reported position. That's forecast to move, some validated at this time, but to move down to 15,000 from where it was at a high back in August. And that is a consequence of significant resource allocation, of course, through our governance initiatives to treat first new outpatient appointments. We are seeing over 2,000 patients per week now, and that is dramatically improving our performance in this area. We're working to see if there is a specialty issue in terms of delivery, but those kind of numbers will still move to when we move to a zero position on over 52 weeks. But we do need to make sure that there isn't a subspecialty issue where we can't actually get ID medical to support us in the provision of those services. Very quickly, just to mention on performance of stages as well. So the patients waiting beyond 2 years for access to routine treatment across outpatient appointments through to completion of their treatment, ultimately to procedure at stage 4. We have seen a movement. We've opened 10,000 at one point, of course, back only 9 months ago. We're down to 4,600. That is a 55% improvement in access for the local population. However, that is not at the rate that we had hoped. It's not given the access that we'd hoped for. And we are continuing to progress and look to work in the final quarter of the year with Welsh Government colleagues, as well as work with internally within teams and professionals to understand if we can improve on that performance still further. The report does target 3,800 patients waiting by 31st December. There is opportunity in there through some of the additionality that's been commissioned as part of the 15,000 outpatient procedures effectively through Welsh Government colleagues that could improve that position still further. But we're working on 3,800 at this time at 31st of December. And we're treating the additionality through insourcing and outsourcing as an opportunity to improve our performance still further beyond that point. As I say, Q4, we have referenced Q4 in the report, but we are still working through that position. And I'll just pause there if I may and just see if colleagues would like to come in regards with other areas of the report. So if I hand over to Anthony first.
Yeah, diolch yn iawn.
Diolch. I think I've covered most of the things in the quality report. Just to note that in the integrated performance report, we do identify October data, which hasn't been as part of the quality report, and the 3 never events. We're just identifying whether they're actual true never events at the moment, and we will be commencing the investigations.
Yeah.
George?
Yeah, just to note that sickness has increased slightly, but to note that we are still have the lowest rate of the 6 largest health boards in Wales. And also, I guess just to note Jane's point earlier about staff sickness and vaccinations, and just to re-emphasise that point. We've seen significant improvement in nurse vacancy rates, which is really good, and also continual improvement with the LDR rates. Thank you.
Thank you, George. And then finally, if I may hand over to Tamina, just to quickly straight over to me.
Just trying to get right down to the detail of that. I mean, we've had a very detailed discussion, haven't we, about the UC data. So I guess if there's any particular questions on that, be happy to take that. That's probably the best thing to do just in terms of time.
Yeah, thank you. Thank you, Chair. So open to any questions.
Diolch yn iawn. You'll sort the question Gareth cynta ar ôl.
Just very quick. I mean, I think, yeah, what it is, I think that particularly the sort of headline report is really helpful and shows the discrete, let's say, the degree of challenge that we face. I just got one small point, which is in the full report, and it's about overdue follow-ups, because I know we were making we had a process of validating those because we thought the number was inflated. And I would understand if that work had been taking a bit of a backseat because of all the pressure on plans there. But I just wanted to check if that is why it is. Yeah, that's fine. Which, as I said, I understand. But yeah, okay.
Yeah. Rhywun arall? Na, felly ysol wedyn o'n i ddod y canol fel. Just the ateb of Claire?
Sorry, I'm a bit late putting my hand up. So I think this gives us a clear indication of where we think we'll be at year end with things like 104-week waits. When we come on financial report, I'm just looking for the alignment between the 82 million non-recurrent funding and some of those national targets. So, yeah. So do you want me to let you answer that in a few minutes?
Oh, that'll give me a few minutes to think the answer as well, won't it? Yes, absolutely.
Okay. It's just to understand.
Yeah, what the
great,
implications are.
Yeah, great progress is being made in some of these areas, but I think we're being transparent that we're not expecting to achieve some of the targets we would have liked to by year end. We'll be a little way off some of them, and it's a question about what are the implications other than patient harm and patient safety, which of course is really important, but are there other implications as well that we need to understand?
If I may just build on that, I guess the issue as well is if we're saying that non-clinically facing staff, that we aren't going to be able to work extra hours or whatever, then we've got a big admin support supporting the 60,000 extra outpatients. So, you know, what happens if somebody goes sick there, we say we need to employ somebody different, or so there is that interface. But yeah,
okay, great. Carol, do you want to come in on the performance aspect?
Yeah, thanks very much. And it's just a reminder for the board, I want to say two things really, just a reminder for the board that we are reviewing and working on the integrated performance framework. The aim is to get that back at the end of January. It's quite a lot of work, we might need a bit of help. And that will help us set the right level of reporting at the right level. I think it is something that we'll want to come back to us for, particularly as we develop our strategic intent and our bigger strategic goals. A lot of this measures speed of access. Of course, we want to really make sure that we're fully integrating the experience of care, health inequalities and all of those other elements as well. The second issue I just wanted to make colleagues aware of and draw attention to is a data issue that has come to light, largely come to light because of the additional insourcing announcement. I'm advised that there are specific data management mechanisms in place regarding patients who are on a list or moved to a list where we have insourcing or outsourcing, and that there appears to have been an issue with putting those patients back into the main cohort for reporting. It is a serious issue for us because we want to have confidence in reporting as well, government and the public. So I advised last week that we'll undertake an external review of our reporting and our processes. In the meantime, colleagues in our DDAT department are working at pace to resubmit the data relating to these months, particularly to substantiate whether it is indeed this insourcing outsourcing issue. It's important to say, Gareth, you mentioned the extra 60,000 outpatients. That's been a really significant endeavour for us, and I think in the last 10 weeks or so, we've seen 17,500 additional patients through those weekend clinics. So the data issue doesn't affect us seeing patients. That's the main thing that I'm trying to say here. We are then seeing the curve move down in our 52-week first out patients, which is really pleasing. There will be some patients who go back on the list, of course, because they need a diagnostic test or something like that. We believe that's where the issue has been with the data. It's not satisfactory. We will and are taking urgent action on this. and we are liaising closely with government officials and ECH as well.
Diolch yn fawr iawn. Rhyw cwestiynau yn sylwadau ynglyn â'r adroddiad?
Thank you. Any questions or comments?
Nad oes.
If not, it's clear where we need to do the work. It's clear where we need to make progress, as already indicated. And we hope that the next weeks and months will see the appropriate progress, because we have had difficulties making progress in certain areas around access, as indicated before. We hope to see progress in the next few weeks. Happy to accept the content. Thank you for the report and for the work. Next report, 3.7, Finance Report. Russell.
So I'll take you through the key headlines if I may, and then happy to take questions and hopefully try and answer some questions as we go as well. So year-to-date position, £16.3 million as a deficit place. And our actual risk to delivery is slightly higher than that because, of course, we map that through, it's about 32 million, but we do have some further risk pressures that will impact on our ability to do that. Break even, mainly the Welsh risk pool, where there is a commitment and every health board is being asked to disregard around that position. So that's something that's outside the 16.3 million now, so that takes us up to about £40 million worth of risk. We have got some areas that potentially we will be supported on through national pressures, which brings that down to about £34 million as a risk profile for us. Where we've got financial exposure and cost overruns, we've got capacity areas open still, which everyone's averted to, and some health area, mental health placements, which are really high class for us. Those elements predominantly driving a cost position. We've also got tariff impact, so we have a lot of cross-border activity. Unfortunately, for the activity that we send, the inflationary price moves within the national tariff for England is slightly higher than the cost uplift factor. So that's funded to us at about 2.83%, and some of those prices are around 13%. So we've got an inflationary charge an issue. Continuing healthcare as well always outstrips the resources that were allocated, so 1.77%, and we're looking at 5 and 6% of risk continually around those care and those third sector partners. So we are experiencing some challenge on inflationary pressures as well, of course. We are having discussions about how we mitigate those positions and going forward. We believe we've got around £8 to £9 million worth of mitigations we need to get full line of sight to deliver the baseline plan position. And in doing so, therefore, we positions that are allocated to the 82 million. The 82 million, of course, 40 million of that was given to support a financial deficit within the health board. The other 42 was given to support transformation and improvement within the health board. We have committed that resource substantially across many areas. Good examples are cancer support services, but essentially that resource is committed £37 million within existing baseline service. We have got some resource through transformation improvement team and some resource rented force to support infrastructure with capacity around workforce management, etc. So those elements will be refreshed. I know that we've gone through those again because the enabling actions have caused us to reprioritise and rethink where that resource would be best utilised. I know that work is progressing and we've taken that through key figures of completion. So you'll see that alignment. We've also had lots of non-recurrent resources this year, so there's been quite a lot of initiatives. So the outpatients initiatives, 45,000 in sourcing, 15,000 local in sourcing. We've also received £5 million from Welsh Government to support 104 delivering improved access for patients waiting for routine appointments for over 2 years. And so building all that resource in, 3.5 million, 3.6 million for diagnostic support as well, on top of the 34 million that is now in our baseline currently. And we have put a mapping piece of work so that we can show that chart in the private session for the board. So we've got that full decision on. And from that log, you'll see that there's quite a lot of initiatives, and that's taken a lot of time. I've got to get our teams to deliver. Having said that, we need to get to a concluding position of a line of sight on break even. And we don't have that as we speak today. And the executive team are working through how we can get to a mitigation process. When we had these discussions at the health board when we met previously, we agreed to set forward a financial oversight group. We have met, and we'll continue to meet to provide oversight to the measures that we put forward in order to line of sight to deliver. If we don't get there, the £82 million is at risk, and clearly £40 million is purely to support break-even position. So we'll find it very, very difficult, I guess, to take that money out and maintain existing service provision. The only other thing I'll just mention very quickly, Chair, if I may, just in terms of the capital position, says we have a significant capital programme still, 57.2 million, and we have secured the additional release of results all funded now. And so, whilst in the report it's showing that as transitional and awaiting, we have secured that funding. So, programme is now balanced. There is small pressure being funded now, of course. And we've spent around £20 million of that resource so far, and we continue to work with Stuart and the team and wider the medical equipment colleagues in order to try and de-risk that programme as we go towards 31st of March, so that we're not risking going over or being under by more than £500,000, which is our responsibility to be within on that capital allocation. I'll leave it there.
Diolch yn iawn am yr adroddiad yna ar eglurdeb ynglyn â'r llwybr.
Thank you for that report on the clarity as to the pathway from now until the end of the financial year. Questions or comments? Gareth, as the chair.
Just to say, I mean, first of all, there was some good news here, like the capital spend. I think, I'm really glad to see that back. I mean, the only point I really want to pick up is, I absolutely understand the imperative of trying to get a balanced outturn. But I am not convinced, and we had a brief discussion yesterday, I think we'll have a little bit of time in the private board, that it is actually feasible for the finance department to vet or non-pay, non-clinical expenditure. I don't know how many items it is every month. And I think in a way, and I have some suggestions which I think we'll discuss elsewhere, but other ways of doing that, which I think are more transparent, because I think in reality, better to say this just isn't happening than to clog up a lot of time when people have putting in submissions and people scrutinising submissions. So I'm just saying that in public because it's, we're allowed to have a difference of opinion, aren't we? But I just worry whether this isn't the right way of doing it, even though I absolutely accept we need to limit our expenditure in some fairly drastic ways. So.
Okay. Yeah, we'll come back to that. Bertha?
I'm aware that we're probably the only health board that's got near balance. A good question for me is looking at that layout between balance in the books and providing some care that's needed. Now, I'm not sure where that debate or that exploration should take place, but I just think it's one that I should consider. That's okay to raise.
Yeah. And in all my meetings with the Cabinet Secretary, he does scrutinise our financial performance and stresses that we need to reach a balanced budget, and he reiterated that in our public accountability meeting last week. However, I think there is a discussion to be had. What are the implications if you don't reach a balanced budget? And I don't think anybody knows the answer to that at the moment. But yeah, it's a good question, and the balance between the care and ensuring we're providing the services at the level required, and then the financial pressure. Yeah, we could debate that all day possibly, but Paul,
It's sort of following on from you, Chair. what was said, that you don't have line of sight to get to a balanced outturn. And you've got 8 weeks to go to the end of Q3. So in the next 8 weeks, you've got to get to a point where you know what you're going to do, because otherwise you won't be able to achieve it. So we've got 8 weeks to actually decide what needs to be done and whether it can be done, which is really quite a tall order. But I think by the next board, we need to know what that is.
Yeah.
Because you won't have time to turn anything around. Even at the end of Q3, there's hardly time to turn it around.
Yeah, that's a really significant point at this juncture, as they say, we're running out of road.
Yep.
So it becomes even more difficult the less road you have, as it were. Anyone else? If not, Carol, and then we'll go to Russ to pick up some of the points, please.
Yeah, and I just wonder if I respond up to Gareth's point about changing the process on non-pay. I think there's a recognition, we spend a lot of money on non-paid items. It's just whether we should have
What do we mean by non-pay for everybody to understand?
Non-pay will be buying chairs, desks, some of it will be equipment, toner for a printer, yeah, those sorts of things. And you know, I've worked in the NHS a long time, so we've had, you know, bans on staples and all of those sorts of things through the era. This is an organisation with such a large budget that actually paying attention to some of those areas actually can give a tangible sort of release of funding. We spend so much money. I think, Gareth, what I hear you saying is something about the process. And what we have heard a lot is in the organisation, which is part of our changing our operating model and our approach, is it's a long no rather than a quick no.
Yeah, exactly.
And so it may be that for this period, we're able to say a quick. And I know that sounds really hard, but there are some significant issues if we can't reach a balanced position, not least that government does have this money on a piece of string. And if they pull that string, it makes next year even harder than this year. And even harder based on a draft budget, that is already very, very difficult. So, you know, is this a stitch in time saves nine, so to speak, so that we don't risk that? And that's why I wanted to really respond to Earthers. We've got to do it all. But there's an even bigger impact if we can't reach break even here.
Yeah, Russ, any response to some points, please?
Yeah, absolutely. So it is 2% subjectives within other expenditures. So stationery is not an area that we target. So what I think I'll do is I'll share the subjectives, and then within my team department, we provide an oversight of those. It is time consuming. It is not something we wish colleagues to spend a lot of time on. Clearly, it is not. But within its other expenditure within that non-clinical categorisation. So I'll make sure that language is very tight for when we report again. And there's about 3.8 million that we spend through that other category every month, just because we are such magnitude that we spend just shy of £210 million per month. So although that 3.8 million is quite a small percentage, with 4 months to go, it adds up to a big figure. And clearly, we're looking at a 20 to 25 million pound challenge between now and the end of the year. So it's looking at that in percentage terms. You know, the reality is there's an opportunity there still. Have we got the balance right? I think that's a really good question. I think it'd be you know, if we didn't have 82 million pounds non-recurrently conditional based on an allocation going into the new year, that is a really challenging conversation for us to have. When you look at the pro quo having to decide where we cut because we don't get that resource to the new financial year, it puts a bit more connotation to that question, a bit more difficulty to answer. But I think we are well resourced in terms of the allocation. We just need to move in terms of our efficiency and productivity, I guess. And we all kind of know we're on that journey. And then I think, Paul, your question is absolutely right. We will get to a position where we run out of road. We do need to be forecasting our models. We might get to a position where we get, as a board, to a place where we can't close that gap. It works out at about just over 1% of our spend. So it's within our grasp of 1%. But if we don't believe we can make those changes, then we will get into a position where we're having conversations about an adverse position and, you know, having discussions with lots of the colleagues about what that means for the new financial year and those contingent allocation.
Diolch yn iawn. Pawb yn hapus I dderbyn y adroddiad sgolch yn dda gan
So everyone happy to accept the report and to thank you for the work, accepting where we're at in relation to our financial performance and in the hope that we can reach the aim by the end of the financial year. 4.1 next. A report that comes to us regularly about staffing, nursing staffing. I will turn to Angela just to outline some of the main features.
So this is our 6-monthly review of nurse staffing paper. It is part of the legislation that I present this to the Health Board with the duty to calculate and take steps to maintain nurse staffing levels. I can give assurance that we have reviewed the nurse staffing within the ward areas within the 25B part of the Act. Russ and I and colleagues met with the teams to look at their requests for increased staffing levels. I wasn't in the mind to support the request because the information provided did not suggest that they needed to be elevated. There was a very small number of requests. We've asked them to look at their information and provide us the next 6-month update, any more mitigations. We have obviously identified that should there be a need from the patient safety perspective and a quality perspective, temporary staffing can be utilised in a ad hoc way, but we wouldn't be increasing the establishments at this time. Happy to take any questions.
Iawn, unrhyw sylw, questions off there?
Any comments or questions? Everyone happy to accept that we are complying? That the report provides that assurance, James. Thank you. So the audit committee next. Eartha, are you going to do this? Because Paul is new. But Paul will be doing so from now onwards.
Will now be chairing the audit committee who will be presenting reports at the next board. At our last meeting, we did focus quite a lot on the consultant job planning. He's very pleased to confirm there that there are really strong specific plans in place to kind of work on that, and also that it is coming back to the December audit committee. I think the other point that probably is worth mentioning is that concerns were raised by internal audit and Audit Wales concerning management responses. We discussed that at the development session, and we will be taking that forward in relation to how we actually review if the actions and learning from the original audits are embedded. So we are taking that forward with perhaps a new perspective. I won't read anything else. You've had that paper there. If anyone's got any questions, please try and read it.
Diolch yn iawn, Eartha. Unrhyw gwestiwn sylw I Eartha?
Any questions for Eartha? If not, can we thank Eartha for that report and the work? 4.3 is the next item. Risk management, and I'll turn.
Reports. So we have reviewed the risks. We had the discussion at the board development session, and it has been through executive and teams. I think just wanted to recognise we've done a significant amount of work on the governance and the process on risk in the last 18 months. It's about how we manage these risks going forward. So certainly that's a priority for the executive committee, because some of the actions around the risk, they're not really right actions, I don't think, in terms of reducing increasing the controls where there's gaps. I think you'll see in the paper I've highlighted that really looking across the year around, there's been very minimal change in risk in the last year. So we have had those discussions at the executive committee, and then there'll be further committees throughout the year to really closely monitoring to make sure that's driving those down. I want to just highlight the earlier conversation we had in relation to urgent and emergency care, the risk within just because the process and it going through committees hasn't quite been updated. I've referred to the most contemporaneous position in the report that will be is in the process of being updated. Just a couple of other high level points was the risk appetite is included in the papers. We have taken that through our informal course to prove that, as well as the business management framework in the supporting papers. And just, I suppose, last point before I take any questions, just really wanted to congratulate the risk management team. We were successful in winning risk management team of the year award at a national event, the Chartered Institute of Risk Management, up against some big players like Nationwide, Rolls-Royce, a whole range. We were nominated 5 awards. You have to put in to get through that, but having won the risk management team of the year award, I think that's a really proud moment. I think personally because it demonstrates the work we've done in taking forward the governance and assurance in a very complex system, and that's not recognised by the award. So I just really wanted to congratulate the risk management team for all the efforts they've in the last year have put forward. Only question
Diolch yn iawn, and I'm sure we wish to add to the congratulations for the risk team. They do a lot of work, and we're really grateful for the contribution. And in the wider context of governance, we can really take assurance around the work that there is in governance and the support that's given us to as a board. We can take confidence in that. So the risk work and the wider work as well, we want to say big thank you and huge congratulations that has been acknowledged as well. So da iawn, diolch yn iawn. Unrhyw gwestiynau ar hynny? Unrhyw un? Os nad oes.
Any questions? If not,
sort of as chair of PFIG, I did just want to make the point that I think the system is working well with the scrutiny committees as well. That's as it could be. So.
Yeah.
It's just to ask, 10 of the risks are above risk appetite. Are they intractable? Can they be reduced? Or do we just have to sort of have a rethink and say, oh, well, there we are, we have to live with that level of risk?
Yeah, well, Big Pammy first and then Carol.
But I would say they have to be reduced because they are above the level of risk that we would wish to accept as an organisation. I was in that process. I think we absolutely do need to make sure we drive these down. I think we've heard today lots of the plans in place which will strengthen some of that, but my view certainly the number of the quality and safety risks, they are above a level that the board would wish to tolerate, so we need to actually do that.
Yeah. Well, let me just follow that, because I think there's an important point that we have decided as a board our risk appetite, and we've done that because we've had a balanced view that will mean in terms of achieving what. So if those risks score higher than that appetite, then we definitely need to address it. Otherwise, there's no point us agreeing a risk appetite. And the second point is that risk is related to performance. So the level of the risk increases when the performance doesn't reach the level required. So there is that interaction. So for us to drive the risks down, we need to improve our performance. Carol, on that point.
Yeah, so on risk management, I did parallel lines, which is really what Pam was saying is we've got a lot of parallel lines, which is the risk is above the appetite level. So it just demonstrates that our actions are not the right actions and that are not having the intended impact. On this issue of intractability, that's the word, I think if we're not able to reduce the risks, it means we need to be perhaps bolder in our strategic approach to changing the system that helps us therefore to reduce the risk. And it's really we must push people harder. It's usually we must redesign something if it is just not bringing the level of service that we need. So you know, it just go back to the UEC discussion. That whole system needs redesign. We know that more community. Less focus on hospital care until we've really got underneath that and driven a systematic change. We will always have some level of risk. In the meantime, we've got to take more actions to reduce the short-term risk. So that's sort of different timeframes, I think, on that.
Yeah, it's a really important point that the risk register is an indicator, isn't it? It's like a barometer, if you like. It ties in with the performance, doesn't it? And as Carol said, what it's telling us is that what you're doing currently isn't working. So don't press it harder, don't get a bigger hammer, but rather get a different one, if I can put it like that. And that's something I think we need to use the risk register to help inform us about.
Yeah, you know, good. I have high expectations. You know, high performing organisations will be using their risk registers really, really well to manage their business. And I always want to say to board members, you know, is there anything on this register we're not having conversations?
Yes,
yes. Because if there is, you question, well,
yeah.
Why is it there?
So I think that's where I just really needed to get to, but it's about the robustness. I think that was a really good question.
Diolch yn iawn. Pawb yn hapus felly I gymryd drwy
So everyone happy to approve?
I'll be very quick, Chair. I think I think it links back to that earlier agenda, isn't it? So it is about how we utilise the resources and empowering our staff to do so, the business case theory and models. So we have an opportunity to mitigate some of these risks by changing how we use and distribute our services and deliver our services and reprioritise them. And I think too often the risk register is used as a means of handing over the risk as opposed to managing risk. And if we can get that shift, then I think we'll be in a better place.
Yeah, we don't want people to say, oh, it's on the risk register. You know, that's sorted now. We put it on the risk register. Okay, diolch yn iawn. Pawb yn hapus felly gymryd drwy adroddiad.
Everyone happy to approve the report and to note what is happening in relation to the risks. We've talked to the team. We'll make sure that everything is noted and that the team are thanked and congratulated for the award given. Everyone happy to approve the framework for 2025-26, please. That's what we're asked to do today. Thank you. 4.4, the corporate governance report.
The usual paper with recommendations. Just a couple I wanted just to allow the try and supporting paper to take out the weight. You'll see the joint committee, there's amendments, standing orders for the joint functioning committee, which are appended to our standing orders. So we just need to those issued by direction. And also there's been Law Wales policy, which has been through the joint committee, I believe this week. We did take it through Quality and Safety Committee, and following that committee, I did go back to the joint committee with some comments around some of the so that was attached for us to ratify. We've got the usual clinicians, doctors, but also I have attached the work we've been doing on 4 visits protocol. We are working on a plan, a structured plan for 2026, as agreed. We agreed we would ensure that the visits are aligned to strategic matters. There will always be visits which all members will wish to take, but this is making sure it's more strategic as per the discussion. Diolch yn fawr.
Diolch yn iawn, Pam. Diolch am y gwaith ar y adroddiad. Rwy'n gwestiwn neu sylw gan
Thank you for the work and the report. Any comments? If not, can we thank you and the team for all of the work. We're very grateful for every contribution by you and the work done to maintain the system or to support the system. I know it's an exceptionally busy period, so thank you very much. Everyone happy to accept the report? Next, item 4.5 is the reports from the chairs of the committee and the advisory groups. And as usual, I'll ask everyone to confirm whether or not they want to confirm, and otherwise we will accept the content of those reports. It's just an opportunity for any chair to highlight anything or to ask a question. Otherwise, we will accept the content. Everyone happy? Thank you to everyone for that work. I think we've discussed all of the items on the agenda, so can I thank everyone for their contributions. This brings us to the end of the meeting today. Could I please thank the translators, Sioned, here in the hall and Lowry online. There were few difficulties with the technology, but thank you very much for persevering and for that service. Can I also thank Laura, Philippa and everyone else who's been involved in ensuring that this meeting takes place. You've been here early this morning setting up, so thank you for that and for your support. And we'll look forward to the next meeting that will take place back in Llandudno. Some of us like Bangor, but we'll go back to Venue Cymru for the next meeting, which is on the 29th of January 2026 then. So we're looking forward to that meeting. Thank you, all of you who've contributed today. Quite often we have these meetings at the end of a busy week and a busy month. So thank you to everyone for your work and contributions. It is very much appreciated. We're going to move to a pattern from the next meeting onwards. I'll ask someone beforehand to ask about monitoring the meeting and comments at the end. Following Pam's suggestion, I think it will be an opportunity to have some insight and to share people's views. In the meantime, if you do have any comments and anything we should be doing differently, happy to do so. It's been a meeting where we've given consideration to a number of important issues. I hope they have been considered adequately. It's always a battle to ensure that we do so. And we have run over the time allocated. Nonetheless, I think it was important to have these discussions around health and wellbeing centres and performance in the emergency departments in particular. That has taken a lot of our time, in addition to the work around strategic planning and the work in Tywyn, for instance. Any comments before we conclude? Everyone happy? Thank you. This therefore brings the meeting to an end. I'll now suggest that we close and that the press and the media leave in accordance with section 1(2) for public services and access to meetings, 1960 Act. Is everyone happy for us to do so? That brings
recording stop.